Check one. Hello. Check one. Check. ঠিক আছে।
Check. Hello. Hello. Check. Check. Hello. Hello. Check. Hello. check, hello, check, check, check.
Check, hello. Hello, check. Check, hello. Hello, check. Hello, check. Check, hello. Hello, check. হ্যালো চেক বাইরে ঠিক আছে প্রেশার আছে আমি এখানে পাচ্ছি না হুম হ্যালো চেক তাহলে আমি ওটা একটু বাড়িয়ে দেবো তাহলেই হয়ে যাবে চেক 1 2 হ্যালো চেক চেক হ্যালো হ্যালো চেক 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 হ্যাঁ
Actually, that answer is sorry from our side. Actually, there is little bit of delay due to some technical reason. So kindly excuse us. For we'll be delaying for around half an hour.
Fully excused and good luck.
Sir.
Good luck. Good luck. Good luck. Dr. Harper, good morning.
Morning, sir.
Good morning. Good morning. So you complete the quiz first. Okay.
Good morning, sir. Just give us 15-20 minutes more.
Right.
Well, we'll start with Dr. Tariq because he has a working day in Doha. So he wants to, after his presentation, he wants to join his work. So after that, the sequence, Anil sir, you all will be taking over from there.
Okay. Please
Good morning, Ansari sir. I can't see you, sir. I'm seeing Dr. Anil.
But my video is not available there.
They just wanted to check your video is working well. That's all.
But I can see in the gallery.
Okay.
Myself.
Great, sir. Great.
Okay.
Over to you, Samir.
Good morning, all. From the instruction from the organizing team, we will be starting quiz at sharp 9 a.m. Before that, let me introduce the rules and regulations what I have made. Because of time constraint, for about 20 minutes, we'll have to conduct it. I have made 50 questions total. So a total 30 initial first part will be 30 MCQs. Each carries 4 marks, negative mark 1 for wrong answer, and 0 mark for non-attempted questions. And in section 2 or part 2, true and false or fill in the blanks, 20 number of questions, 2 marks for the correct answer. If the answers are 2, then each carries 1 mark, and there is no negative mark in this part. Total time is 20 minutes and discussion is 10 minutes. So good luck to all of you. Let's hope more participation. Actually, a little bit of delay probably due to last night, I think. Let's see. So IPCA people are there, those who, they may help me. Total how many registration till now for quiz? 1919. So we'll start after 10 minutes. And great news for all the participants that we are having winner and runners up. They will be awarded with a academic financial grant for any study material like books and others. For the oath, about 15,000 for the winner and 10,000 for the runners up. And for this, I must thank IPCA people for supporting this academic grant. And let's hope.
Samir,
Yes, sir.
I would like to add, Quizmaster's decision will be final. No, I don't know whether you have announced or not.
Thank you.
You follow my point. Your answer, they must not argue later on. Sir, that is this. Campbell में ऐसा दिया है, इसी में दिया है, वो होवे ना. So your decision, is final.
Probably he is not audible. Come here. Rajan sir, are you here or you have left already?
No, I am there. I am there.
So we will like to see you inside the hall. It will be our pleasure.
I am coming. I am coming. I am coming. Samir.
Yes,
Samir.
sir.
So Jagabondhu, Jagannath, Haribol, Haribol.
Yeah, thank you, sir.
All the best. I am coming. I am coming.
Actually, practically, I have planned to have more questions because probably the time will be less. So we have taken 30 MCQs, but in the printed sheet, there are 50 questions. I request all to attempt 30 questions from MCQ section. And from part 2, we can write down 1 to 20 number question. And you can answer, ask for true or false, or fill in the blanks, ask for the questions. No, no. मैं काम किया था इनको कट कर सकता था एक्चुअली पहले से प्रिंटेड सेट में 50 क्वेश्चंस अच्छा प्रिंटेड हो
Okay, by the time quiz is going to start, by the time I have one announcement regarding the registration for Rajgir conference. You people, all the students as well as the delegates are requested to get registered for Rajgir conference 2022. That is going to happen in October 14th, 15th. The counter is available outside. Please take the advantage of early bird registration. Registration fee is only 3,500. Okay, thank you. For students, only to 2,000. For students, only 2,000. Please take the advantage of get registration and early bird registration. Okay, thank you.
But they will take the advantage if they are student now. Yes, sir.
Samir,
Yes, sir.
why don't you on your video?
Video, yeah.
अपना
please-
video थोड़ा दिखा दो. That will maybe more hybrid like, you know.
Okay.
Looking better. Yeah. That is it. So now it is much better. We can see you. And very nice, very nice.
सर आप आ जाइए अंदर में.
I'm coming. I'm in the lift. I conducted this particular quiz in 96 at Siliguri when Rajiv TP was the winner.
इसको प्रोजेक्ट कर दो. अच्छा वो दूसरा वाला हटा देना. दूसरा सुनो. Yeah.
Once the ureter is dissected.
So now total how many is 20. So we'll be starting shortly within 5 minutes. It's 8:56. So surf 9, I will be starting, and please be careful when answering the first part because there is negative marking in each question. And each question display will be maximum for 20 seconds.
Once the ureter is dissected all around and hanging freely, then medial or lateral blood supply does not matter. But what matter is the blood supply.
Let's move. Good morning, all. And first of all, I must tell there might be some question differences or opinion differences, but because I am quiz master, I may have the privilege to announce that whatever I am deciding, that will be final. I may be begged. Okay, the winner will be winner and runners up. Let's cheer. Rules I have told already. Let's go for the first question. Father of endoscopy. These are the choice. You can go for A, B, C, D. Philip Boggini, Harold Hopkins, Maximilian Nies, and Desiree Max. Question number 2. The term posted was first used by him. Who is this person? Question number 3. This man introduced the revolutionary procedure known ICSI. Probably all of us must be knowing what ICSI is. Question number 4. Identify the device. Question number 5. What is this diagnosis? Spot the diagnosis. Image is visible. Question number 6. What is this crystal structure shown? The image of electron micrograph. Which category of prostatitis is NIS classification insignificant number of white blood cells in expressed prostatic secretion, that is EPS, post prostatic masses, urine, sediment, BB3 or semen? This is question 7. Question number 8, stereotactic radiotherapy, that is radiosurgery actually, is also known as the main determinants of uric acid stones formation are all except question 9. Question number 10, a syndrome of abnormal collecting duct formation characterized by inability to acidify the urine in the presence of systemic acidosis is known as nitrofurantoin is effective against common uropathogen, but it is not effective against which of these organisms? This is question 11. Question number 12. The first open prostatectomy for carcinoma through a perineal approach was performed by question 13. The safest place to percutaneous access of the renal collecting system is in which technique of varicocelectomy arteries are not preserved? Just to remind, there will be negative mark for this part of questions, MCQs. In performing nerve-sparing radical prostatectomy, retropubic prostatectomy, the neurovascular bundles are identified At which point? Please select the correct progression of arterial supply to the kidney. Just go through the sequence or number of artery from the beginning to the end. Because it is end artery, go for the correct sequence. The arterial supply to the adrenal gland originates from all except Lapides. Introduce the concept of what? These are the options. Before starting laser firing in RIRS, find the wrong answer. Ionizing radiation. Most important risk is best modality for investigation when suspecting renal colic. These are the options. Uroselective alpha blocker used in BEP. Find the correct answer. In case of UDT, that is undescended testis. Which one is correct? Shockwave therapy in erectile dysfunction. What it causes? What is the benefit of shockwave therapy in erectile dysfunction? During left adrenalectomy through laparoscopic route, sometimes there is troubles of bleeding from medial side. Which is the cause among these four? Out of these four answer, which is not a basket? In priapism, which clinical examination finding is diagnostic? CVA, the common bladder dysfunction, CVA cerebrovascular accidents. What is the common dysfunction of the bladder? In case of left testicular malignancy, the first group of node to be affected are in which technique of sorry, this question has been repeated. I mean, this question should be cancelled. Let us not mark it, or you can attempt also. So, let us go for the part 2. Can answer from 1 to 20. Identify the instrument. Again, what is this? Identify these sets of instruments used in some urological disease, but these are very less used now. Identify the type of stone. Again, identify the instrument and with which degree of telescope is used. In this case, this question has 2 parts. So you can answer 2 and each carries 1 mark. In which year Indian Journal of Urology was established? And who is the publisher now? This is a sputter, CCT urogram. What is this defect? And you can answer the diagnosis. Answer true or false. Klinefelter syndrome is the most common genetic cause of infertility. You can write down true or false. These are various terms used in some specific surgery in neurology. The words are dancing, chipping, boring, or popcorning. Identify the person. Bimix is a mixture of triple wording is seen in which serological condition? Again, identify this structure and where does this commonly occur? Spot the diagnosis and what is the treatment? Twenty-year female with urine sample and the duration is 3 weeks. What is the diagnosis and what is the treatment? This is the cystoscopic image of ureteric orifice. Write down the diagnosis and treatment. Treatment of phosphaturia is vitamin C. State true or false. Identify the textbook and which edition. Again, state true or false. In post-renal transplant patient with severe pain and swelling of the operative site, the probable diagnosis is acute rejection. State true or false. Half-life of serum free PSA is around 3 days. So our 20 minutes is over already. Please collect the answer sheets. Collected? C is over. Probably all have submitted the answer sheets. Should I start with the answer session? Wait. Oh. Quickly, we'll go through the answers because we'll have 10 minutes for this part. So this is the father of endoscopy. The answer is D. The term prostate was first used by him. The answer is B. ICSI was first started by. The answer is B. Palermo. Question number 4. The answer is B. Question number 5. The answer is A. Question number 6. The answer is C. Oxalate monohydrate. And this question number 7, the answer is B. This is category 3B. Stereotactic radiotherapy or radiosurgery, the answer is A. Cyberknife. The main determinant of uric acid stone formation, the exception is D. For question number 10, the answer is C. That is type 1. For question 11, nitrofurantoin is not effective against Pseudomonas. Answer is C. Question number 12, the answer is B. Safest place is Calicial formation. This question number 14, the answer is A. Question number 15. The answer is D. That is anterolateral surface of the prostate. The correct sequence of arterial supply, answer is B. Renal artery, segmental artery, interlobar, arcuate artery, interlobular, and afferent artery. Question number 17. The answer is D. Supraphrenic artery is not supplying the adrenal gland. Lapidus introduced the concept of CIC. And question answer is B. Before starting laser firing in RIRS, the answer is C. The pilot light must be seen. This is a little bit tricky. Pilot light can be seen, but nowadays pilot light is not a must. Better you should avoid it. In case of ionogen radiation, the risk is developing malignancy. Best modality of investigation is CT-KUB. Uroselective alpha blocker, the answer is B and C, both are correct. In case of UDT, the most probable answer is associated with patent processus vaginalis. Shockwave therapy in ED, the answer is neovascularization of corpus cavernosa, because usually it helps in erectile dysfunction, though there is not a widely used technique. In lap adrenalectomy, sometimes there is bleeding from medial side, but usually from IBC it may be controlled easily. But the answer is C. It is from infraphrenic vein because it was lying more or less posterior aspect and sometimes less identified. From this, entrap is not a basket. Answer is C, 26. In 27, priapism, the clinical examination finding, The answer is C. This is typical. The glans is flabby. It's not engorged or painful. Question number 28, CBA. The common dysfunction is detrusor overactivity. Answer C. 29, the first testicular cancer, the first group to be involved, para-aortic group. This is the repetition of question. The answer is A. Coming to part 2, question 1, this is Belfour retractor. This is Millin's bladder retractor. This is filiform bogies. This is uric acid stones. In order to identify the instrument, that is Alvaran Bliss or Alvaran River, and 70-degree telescope is usually used, though these instruments are not used frequently. IJUO has been established in the year 1984, and Medno is the publisher now. The clue is this is a cystogram with Foley's catheter, contrast in the vagina, and there is a small opening, then small track you can visualize. Diagnosis is VVF. Klinefelter syndrome is the most common genetic abnormality for infertility. The answer is true. And for this question, the answer is RIRS. Who has written Atal Bihari Vajpayee? Anybody? The answer is Jack Lapidus, that is American urologist. Bimix is the mixture of papaverine and chlorpromazine. Triple budding is usually seen in PUR with higher degree of reflux. This is jackstone and usually found in urinary bladder. The diagnosis is Fournier's gangrene, complete excision of the tissue, and hyperbaric oxygen is another therapy. This is chyluria, and treatment should be conservative in form of antiviral therapy and avoidance of fatty foods, because she had 3 weeks direction. The cystoscopy finding is Gulf 4 ureter, and ATT should be started after evaluation. Treatment of phosphaturia is vitamin C, that is true. Identify the textbook, that is Smith's Endourology, and it is 4th edition. For this question, the answer is false, but this occurs with venous thrombosis mainly. Half-life of serum free PSA is around 3 days. The answer is false. Free PSA, the half-life is around 2 hours. The 3 days is for total PSA actually. Thank you. The result will be announced soon, and we have completed exactly in 30 minutes. Thank you all for attending the session. We will be announcing the result in next session, in between the next session, and this may be displayed in the website also.
Thank you, Dr. Swain, for excellent conduction of the quiz. Our next session and the last session for the conference is semi-live workshop on pediatric urology and andrology. First, on pediatric urology, may I call upon the stage the faculty, Dr. N. Mallikarjun Reddy, Dr. M.S. Ansari, Dr. Anil Tagwani, and Dr. Tariq Abbas, and the chairpersons, Dr. Harpreet Singh, Dr. Uday Chatterjee, and Dr. Prem Kumar. Huh. Dr. R.G. Gopal Krishnan. Please, sir, on the stage.
Hello, good morning. Good morning, Dr. Anil. You are not audible, sir. Sir, unmute, please.
Yeah. Good morning, Dr. Ansari.
Dr.
Good morning,
Malika.
Dr. Tariq.
Morning, sir. Morning.
Morning.
Good morning.
And
Good morning, everybody.
Tariq, it is almost 7 o'clock there in the Doha.
Yeah, it's 7 o'clock now.
and Dr. Tariq, good morning and assalamu alaikum.
Good morning. Salam alaikum. Thank you very much. Thank you for the great invitation and wonderful arrangement.
Yes,
Dr. Tariq, you are talking with the Professor Ansari. You must be knowing him, but I just introduced you.
Absolutely.
He's a head of pediatric urology department of most prestigious institute of India, that is SGPGI Lucknow.
Good morning, and it's a great honor also to talk with you as well. Thank you very much.
Morning, Ansari boss.
Good morning, sir. Good morning. So I was thinking that you're having a long Sunday morning.
हाँ यार yesterday night was very busy. We slept at 2 o'clock.
So here also, and yesterday there was this Lucknow urology meeting. So I had to skip that because situation was out of control, because there was a presentation in the BAPS also. And yesterday there was a meeting on IAPS is also going now. So there were presentation for the residents also. So suddenly there was a lot of pressure. and Dr. Takwani always keeps pediatric urology in India on toes.
Yeah.
Thank you, boss. Good morning, Malik.
Morning, sir. Morning, Anil boss. Morning, Dr.
Anil. Good morning, Dr. Anil, Dr. Tariq, Dr. Ansari, and Dr. Mallikarjun sir. Can you see us?
Good morning. Yes, we see you.
Yes,
we can see you. Yes.
We can hear you loud. Good morning, everyone. So we are starting semi-live session of pediatric surgery. So this session is an online session. So we have the faculty. Hi, welcome Gopal. And I have Dr. Uday Chatterjee and R.K. Gopal Krishna with me. So can we start without any prelude, any delay? Dr. Tariq, you will be starting first.
Sure, I'm ready.
So I welcome you all to this 30th annual conference of EZ-USICON. So welcome, and we'll begin. Dr. Tariq will be presenting the critical steps of hypospadias repair. So he will be beginning. Dr. Tariq is head of the department at Doha, and he will be presenting the first.
Okay, I will share my screen. So thank you very much for the great invitation, and it's a great honor to present here, and I do appreciate the great arrangement behind the scenes. So is it clear, my screen here?
Yes.
Okay, so I will be talking about hypospadias repair critical steps to be emphasized. I think this one is in the middle of, let me put it this way, maybe. So I will start by a theoretical background, taking the advantage of being the first one to present, and then a semi-live videos at the second half. So I'll be talking about what are the factors impacting on the post-operative outcomes in hypospadias surgery, how to score the severity of hypospadias urethral plate quality and curvature assessment. These are useful when we come for the decision-making and to select which surgery we want to do, and how to perform urethral plate quality and curvature assessment, how to select the proper ideal procedure, optimal urethral plate coverage according to the type of surgery and type of hypospadias. And then when we come to distal hypospadias, we touch on the algorithm of primary distal hypospadias repair, how to perform tip repair and grafted tip, general steps, ventral dartus flap, dorsal application. And when we come to proximal hypospadias, we'll be touching about the differences in the algorithm of proximal hypospadias and ventral corporotomies. So there are several variables that has been taken into consideration whenever we want to decide about the type of surgery or the long-term outcomes of hypospadias. Along the history of hypospadiology, the type of repair has been several times blamed for the outcome. However, how to do these techniques and how to select the types of surgery accordingly is very important as well. And that's what we'll be concentrating on and focusing on in this presentation and in my future research. Level of division of the corpus spongiosum is very important. The curvature, the meatal stenosis, meatal position as well, whether it's proximal or distal, are very important. The size of the penis, whether it's large or long, the glans size, the amount of the dorsal foreskin that will help sometimes in the coverage of the skin. Glans morphology, is it a shallow urethral plate, deep urethral plate, as a surrogate for the urethral plate quality. Gland size, whether it is less than 14 millimeter, larger than 14 millimeter, has been taken into the decision for starting hormonal therapy sometimes, blaming for the complications after surgery. In the last 10 years, when you concentrate in the literature of hypospadiology, you will notice that most of these factors have less attention now. And the most important currently are the urethral plate quality, whether it's favorable or not favorable, the level of division of the corpus spongiosum, and the chordee. Okay, so what we'll be talking for the next 2 minutes is how we classify hypospadias, or how we categorize the urethral plate in hypospadias. We went into the most frequently utilized scoring tool, which is the GMS, and all of us know the GMS, the glans, urethral meatus, and shaft scoring, which divides the glans into 4 grades, the meatus into 4 grades, and shaft into 4 grades. The idea here is that you want to collectively have a more objective scoring tool to classify hypospadias, and then we talk the same language between the surgeons and researchers. However, when we talk about the glans here, it is highly subjective, reflects poorly on the urethral plate quality, and the meatus is a crude way of classifying hypospadias, because sometimes you find a patient with glandular meatus, but actually a severe malformation of the ventral axis of the hypospadias with severe chordee. It's actually proximal hypospadias in severity, or severe hypospadias. This was also often discrepant between the real extent of urethral hypoplasia. The shaft, or what we mean by chordee, often can be determined only intraoperatively. So this is is a good scoring tool, but has a lot of disadvantages. We came to the POST, which is the plate objective scoring tool. It is very simple. You define 3 important landmarks in the urethral plate: A, at the distal extent of the midline of the urethral plate, at the junction, at the mucocutaneous junction, and the B, glandular knobs, and the C, at the coronal glanula. If the AB is more than BC, then this is favorable, like in this situation here. And then you do tip repair safely. If it is less, then it is unfavorable, and then you need to graft the tip. This, at least our approach. We found this with high sensitivity, area under the curve, and reproducibility and inter-observer reliability. Now, that was our initial intention, but we found now recently that the POST score functions not only to divide the urethral plate into favorable and unfavorable, but also to classify the urethral hypoplasia into the distal third, middle third, lower third, infrapubic, according to the number of the POST score. And soon we'll be publishing our results about the relationship between POST and chordee. We have presented in the HIS recently. Okay. Now, so that is our POST score and how we classify, and we will come to how to use it actually during the scoring system. Curvature assessment is very important, how to objectively assess the curvature. And there are different cutoffs that is different between surgeons, institutions, literature, history. Our cutoff is that when we reach 20, we start to do dorsal plication. When we reach 50, we do corporotomies, urethral bed excision. Now, this is very important to have an algorithm clear in your mind and your practice and consensus between all the surgeons. It is very important for the transmission of information, for the transparency, and for the building of an accurate database. Let us see now the most frequently utilized tool in the OR to test curvature, which is the goniometer. Now, in the upper row here, it's only one 3D printed model of penile curvature with a certain degree of curvature. You can see that using the goniometer, we can get three different numbers, 20 degrees, 25 degree, and 30 degree, according to the way that you put it. This is another model here with another curvature. And you can see we get 45, 55, and 65. And each one has a different technique of repair according to your strategy. Another approach to measure curvature is the mobile applications, which are not designed for particularly penile curvature. And you can see in these 6, there are one picture of the penile intraoperative of penile curvature, and you can find that we measured 46, 44, 45, 47, 39, and 51. So this is not reliable. Again, the way that you put the three dots here are very important, and sometimes it can misinterpret the curvature degree, and then you go for an unintentional surgery or incorrect surgery according to your protocol. For the same patient, if you do this way, you go for urethral bed excision, dorsal prolongation, or do nothing as well for the same patient. So for that reason, we came into standardization. So if you take a picture during the surgery, this is the way that we standardize how to take the measurements, how to put the 3 dots, the level of the penile bone at the middle of the 2 axes, ventral and dorsal, you put the Z point, and then at the maximal curvature, you put the Y point, and at the junction with the distal extent of the glans, you put the X. This is more reliable. However, we are working on artificial intelligence and machine learning, how to autonomously take the pictures. How to select the proper ideal procedure for distal hypospadias, as you can see in this picture, is tip repair mainly. And for proximal hypospadias is the stage repair or 2-stage repair. However, there are different techniques, and the best technique is it works in your hands. Now, in our center, we work for distal hypospadias only 2 techniques, dorsal inlay and tip repair, with the teaching of Professor Pipisali as well. So we went into the last or recent publication, are there any benefits of using inlay over tip repair? Now, the result actually that there is a very little superiority of dorsal inlay. However, we believe that there is some sort of hidden superiority of dorsal inlay because of the methodology that has been done, and it has to be selected for unfavorable hypospadias repair. Now, let us finish this theoretical part and go for the type of optimal urethral coverage. To make it simple, for distal hypospadias repair, if it is beyond the mid shaft of the penis, we go for ventral dartus flap. In proximal hypospadias and redo cases, most of the time we go for tunica vaginalis flap, and we will be showing how to take these 2 types of flaps. Our algorithm for distal hypospadias repair, first line, we assess the core D, and we discuss the limits, the pros and cons of how to assess the core D. If it is severe, we go for stage repair. If it is mild or moderate, then we go for the urethral plate assessment, which we meant by the POS score. And then we divide it into favorable, we do tip repair, or unfavorable, we do tip repair. That's why recently, in the last 2 years in our center, it's very straightforward, very reproducible how to navigate through this algorithm of distal hypospadias repair and proximal hypospadias repair, as we will be touching soon. Now, for the assessment as well and the decision making, the POS score can be done pre-operatively, and just to re-emphasize the values here, if it is more than 1 or 1.2, then we go for tip repair. If it is less than 1 or 1.2, then we go for stage repair. If it is more than 1 or 1.3, then we go for unfavorable hypospadias repair. than one, we go for dorsal iliac tip repair. If it is in the middle, we use another marker, which is intraoperative, the urethral plate ratio, which is the urethral plate width before incision divided by the urethral plate width after incision. If the before incision is less than half or 0.4, this is unfavorable, because actually there will be a large raw area that you will be tubularizing. Then if there is a large raw area, then we go for dorsal iliac. If there is a small raw area, we go for tip repair. Now, tip repair. Tip has been popularized by Snodgrass from 1994. Most of the results of tip repair, you notice that the meatus is in the ventral side of the shaft of the penis, because you are not progressing the tip or the A point of the urethral plate, but rather you are pulling it a little bit down. And the modified tip repair, you go below the incision, lateral incision of the U shape of the urethral plate, 3 to 4 millimeter, and then you start your urethroplasty, as you can see here. That's why actually you are increasing the AB point, the future meatus, but at the same time you are bringing the meatus in the ventral aspect of the glans. That's why the dorsal iliac tip repair has the advantage of extending the meatus forward into the apex of the penis. But for that reason, you have to put a graft. Otherwise, the healing of the glands will lead to severe stricture and formation of meatal stenosis, urethral stricture as well, and failure of the surgery. So we'll be talking now. Let me start the videos here. Okay. So when we want to do either tip repair or urethral or dorsal iliac graft, the first thing that we color the urethral plate very nicely, because this will help us when we want to put a graft. Where are the margins that we suture the graft?
Sorry to disturb you, but you have to be a little faster now.
Okay. So this is the midline incision here, and we define the meatus position in the future, and you have to go very deep into the up to reaching the corpora. So that's a very important tip, not a superficial incision. And you have the lateral margins of the urethral plate very well colored. Then you can put your graft easily. How we measure the urethral plate before and after is a very important marker as well, from B point to B point. Let me go for another important point of technique, which is the ventral dartus flap. The ventral dartus covers the ventral side of the penile shaft. And what we do, actually, we go very aggressively into the tissues between the buccal fascia and the ventral dartus and elevate it, so that we have a very healthy ventral dartus, thick and robust. So again, if you want to take the ventral dartus flap, you go into the tissues deep between the buccal fascia and the dartus flap. There is a bloodless space there, and then you continue going distally, and you will have a robust ventral dartus flap. Okay, now we go into the most important thing of correction of penile curvature. It should be in a way that is systematic and reproducible. The dorsal plication, You go in the dorsal midline after marking the maximum point of curvature, and you open the box fascia. You will find the superficial dorsal vein and deep dorsal vein underneath there, and some branches of the nerves there. And then you open the tunica in two parallel lines, about 2 to 3 millimeters apart from each other, two transverse. And then with a non-absorbable suture, you close them in an inverted manner. We take usually 3 sutures. And then we repeat the erection test. It's standard also after the correction, and we can see that it is straight now. Our algorithm for proximal hypospadias is exactly similar to the distal hypospadias. However, most of the time we go for stage repair. Why is that? Because the chordae or the curvature is very severe. However, if we find the curvature is very low and manageable by dorsal plication and the erythral plate quality is good, which rarely happens, we go for either long tip repair or dorsal iliac tip repair. And here we'll be discussing the corporotomies, the superficial corporotomies that has been popularized by Dr. Bibi Sali. So initially, you do erection test, and you can see that we have severe curvature, about 70 degrees. Then in the ventral side of the maximum area of the penile curvature, you do 3 parallel transverse markings and incision of the superficial tunica albuginea. Beveling the knife, you spread between them, taking care not to reach the cavernous area and erectile tissue. Sometimes you need to spread the 2 sides by the edge of the knife. The distance between the three transverse incisions is about 3 to 4 millimeters, and it is from 3 o'clock to 9 o'clock. It should be very wide and deep enough that you open the deep tunica albuginea layer, but not going aggressively into the erectile tissue. The advantage of this also is that you can still do the erection test, and you can see that we secure the straight penis after that severely curved penis. The last point of technique that I want to show here is how to harvest the tunica vaginalis, which is very important for proximal hypospadias and redo surgeries. Opening the hemiscrotal sac. A very important step here is to dissect clearly the margins of the vas and vessels, secure them away, and peel all the tunica vaginalis flap away very easily, exactly like what we do in hernia. And then cut it away, going deep into the internal inguinal ring, and then by that we will be having a very robust and wide flap. So I hope that I covered most important steps in hypospadias repair, and thank you very much.
Thank you, Dr. Tariq. You can hear the clap from the audience for your presentation.
I can hear, yes.
Thank you for joining us early. I know it's 6 o'clock in the Doha. It's what time there?
Now it is 7:25. Yes.
So it's quite early on the Sunday morning. And if there are any questions for Dr. Tariq?
I have a couple of questions, Hardeep.
Yes, sir. Please, sir. Go on, sir. Anil, sir.
So, Tariq, excellent presentation. Thank you very much to join us on short invitation. While doing this superficial corporotomy, do you keep tourniquet or you don't keep?
This is very important question. Actually, we never use tourniquet during even the erection test itself, and particularly during the corporotomies, because it can hide the discoloration of the red discoloration of the corpora and the spongiosa below. So we don't use a tourniquet during the corporotomies. We want to see whenever we touch the erectile tissue and we have bleeding, we stop. That's why we don't use it.
Tariq, would you like to tell us, our audience, why we should not use tourniquet while performing the erection test?
Okay, it is not a wrong thing to use it. However, we don't use it with a very important caveat, because tourniquet sometimes can mask a proximal curvature. That's why we don't like to use it. So we put two deep retractors so that we can see the penile shaft to the level of the pubic bones. And then we do the erectile tissue with a wide pore needle and under rapid infusion of normal saline. So that's why we simulate the erection test, and then we can see the penile shaft up to the pubic bone.
Dr. Tariq?
Yes.
One thing, I think you are scoring at the very beginning, your post score.
Yes.
Have you ever rechecked after application of testosterone in the penis, whether the post score is changing or not?
Okay. Now, basically, it should not change because it is an impression of the urethral plate into the glands. We noticed in one or two cases that there might be a change. We went back with the pictures before and after testosterone, it does not change. So it is very clear for us now that the post score without, before and after does not change.
Thank you.
Dr. Tariq, you are using this graft in all your distal hypospadias. What graft, if you're using, what graft you're using?
We use inner prepucial graft only in unfavorable urethral plates. So when we categorize it as unfavorable, according to the post or urethral plate ratio, we directly put an inner prepucial graft.
And are you doing spongioplasty, the splaying of the carpus spongiosum, which is many people are advocating that the V which is coming, are you dissecting and covering it and bringing it as a layer over your neourethra?
It is not routine. So we do 3 layers. We do the continuous first layer and then interrupted second layer. And if we find a robust, like a very thin hypoplastic tissue, we strive to dissect lateral spongiosa and do some sort of spongioplasty to guard against the verticulum or to support our urethral tube. But we don't do it routinely.
So the biggest problem is in the hyposphere, what I understand is the fistula is always at the junction of the glans and the skin where you join. The Phillips collar is also very, it is defined in some of the glans, and some of the glans it is not defined. How you prevent this fistula formation at the junction of the penoglandular region? That's what's the trick about it? How you go about it?
Okay. Number one, selection of the case, because if you do tip repair, for example, in a very bad plate, then there is a very high pressure inside the glands that most likely will find a way to come superficial and most likely as a fistula. Second thing, a robust tonic ventral dartus flap, a healthy one that will heal and support the tissues. The third thing is a healthy mucosal collar, a very good skin that's not ischemic, that's healthy. All these things we find are supporting to reduce the risk of fistula. I can tell you, for example, in our last series, over more than 120 cases, we have only 1 fistula.
That's
so
wonderful.
We have a very low fistula rate.
Yeah. I have one question to Dr. Abbas and maybe to Dr. Anil Takwani as well. In redo hypospadias, where you do a staged repair, we have sometimes seen you using buccal mucosa for the first stage. Now, I believe this is a common observation in the Indian subcontinent as opposed to the West, that when the buccal mucosa is exposed to the air, it tends to desiccate and shrink. And when you come to the second stage, you find that the buccal mucosa, which was adequate at the time of placement, has shrunk significantly. I believe this is an observation by Dr. Tony Mundy as well, who says that this is a common observation in Arabia and in the Indian subcontinent, but not in the Western world. How do you find a similar observation, and how do you prevent it?
So, Dr. Anil, can I start?
Yeah, Tariq, you take question. Yeah, please.
Yeah,
Go
yeah.
ahead.
So this is a very valid observation. Now, the reason behind that, the buccal mucosa are used into wet atmosphere always, like the saliva, the mouth cavity, and these things. And desiccation, desquamation, and scarring is very frequent. That's why if we use a buccal graft, okay, for first stage repair in proximal, in redo cases, we start a very strict protocol of vacuum physiotherapy with Vaseline or any lubricant or ointment to keep it very moist always. And we go and we select the earlier time to close it, because you want it to go into the wet atmosphere again. So the two things we do, vacuum physiotherapy to stretch it and Vaseline. Second thing, close it as soon as possible.
So the time was short, otherwise he would have shown the vacuum therapy, which is very popularized, very much popularized by the Sidra Doha.
Exactly.
Yeah. So, Adip, shall we move to the next presentation?
One question.
Is there any some time for a question?
Not audible.
Can you hear us?
Yeah. Hello.
Anil?
Yeah. Do we have some time for question, or we move to the second presentation?
One question. Only one question.
So audience, requesting audience to ask last question.
Hello.
Yeah.
Just I'm asking you one question. In case of proximal hypospadias, what do you prefer? You prefer a graft or a flap? And if there is graft, what is the percentage of contracture of your graft?
Okay, it's not wrong to select either one of them. However, what we do is a graft. The shrinkage rate is about 10 to 20% of the width, because we measure it at the time of harvesting the graft, at the time of the implantation, and when we come to the second stage. But it's not wrong to say that a flap can be used.
What is the reason behind to prefer a graft rather than a flap?
Yeah. So this is what we do consistently in our center, popularized by Dr. Bibi Sali, and he used in his initial experience several types of flaps, and he found several types of complications, as we all know, ranging from strictures at the anastomotic areas, diverticula, and we have a very good results now with the grafts, with the stage repair.
Thank you, Dr. Tariq. We will proceed to next presentation. Dr. Anil.
Yeah.
You please start.
Someone has to allow me to share the screen. Requesting host to allow me to share the screen. Yeah.
I think you can share. Dr. Tariq has stopped his sharing.
Yeah. So at the outset, I would like to thanks Council of EZ-Zone as well as Scientific Committee to give me this opportunity to present into the EZ-Zone conference. I'm presenting on a couple of techniques which we use for treating the high-risk reflux patient. So I'm primarily going to demonstrate intravesical ureteric implantation technique only, as I'm not very much versed with the extravesical technique. I learned the modified polytono lead-better technique from my friend Dr. Mitul Parikh. So we all know anti-reflux procedures have a good success rate, which ranges almost 99%. And all these procedures attempt to create a submucosal tunnel, which is 4 to 5 times longer than the width of the ureter being reimplanted. And as we all know, Cohen and polytono lead-better completely intravesical, and Lee-Greger, which is extravesical, have gained the equal amount of popularity in last 5 decades. Why the Cohen is very much favorite of most of us? Because the ease of performing it, if it's effective result point of view, and least complication, as there is a no extravesical act involved, as well as no creation of new meatus, new hiatus, but has the disadvantage of making future retrograde endourological procedures, if required, bit difficult. Regarding Lee-Greger, as bladder is not open, it is this traumatic procedure, but there is a fear of neuropraxia and prolonged catheterization with simultaneous bilateral implantation. So coming to the polytono lead-better procedure, it recreates the new ureteric orifice in orthotopic position. So if in future there are some need of retrograde procedure, it can be done without any issues. And which cases we operate? So we need to categorize these cases into the reflux cases in the low risk and high risk. Whenever we see patients of prenatal hydronephrosis or recurrent febrile UTI, we generally perform the VCUG after the sonography, and then we try to categorize them. So why this categorization? As we want to detect clinically significant or high risk UR, which is dilating UR, to avoid the recurrent febrile UTI and further damages to the kidney. And on another side, we want to avoid detection of clinically insignificant low risk UR to avoid over investigation and unnecessary trauma of the treatment. So who falls into the low risk UR? So low grade reflux, which are non-dilating refluxes, detected under the age of 1 year, high chances of resolution. Mode of presentations, either prenatal hydronephrosis or sibling UR. Without UTI, they are detected, high chances of resolution, or it is clinical course remains very much less risky. And laterality, unilateral reflux resolves earlier than the female bilateral reflux and absence of bowel bladder dysfunction. So these are the couple of examples. Here you can see on the left side, low grade bilateral reflux, and you can see in the DMSS scan there is no at all any lesion. Similarly, on right side there is a unilateral reflux, low grade reflux. Again, you see in the DMSS scan there are no lesions. So what constitute high risk patients? High grade reflux, specifically diagnosed after the febrile UTI, have a risk of renal scarring, renal damage. Already when you do a VCUG, you do DMSS scan, if there is a there are scars or scar into the DMSS scan, they are highly susceptible for the further febrile UTIs and the new scar formation. Bladder dynamics, as we discuss, BBD is creates high risk for all these patients. Ureteral anatomy, we'll see the couple of examples of these. So here you can see, here there is a high grade which was detected following the recurrent UTI, and you can see in the DMSS scan. So little bit about the DMSS scan, you can see here there is a loss of contour and no uptake of the radioisotope. So this is typically a scar. Here there is no loss of contour, just photopenic area. This is representative of acute inflammation. So in this patient, because of previous recurrent infection, there is already scar formation, along with the recent infection has created the inflammation, which is represented by the photopenic area. Again, another example, 12-month male child, 2 episodes of febrile UTI, amounting to the IV antibiotics, constipation, so case of BBD, and as VCOG was not possible in acute infection, the DMSA scan was done. You can see in a top-down approach. There again, you can see some scarring, which is on the peripheral area as well as on the polar area with the photopenic area, which is representative of acute infection. And there you can see high-grade dilating reflux on the right side. Again, severe, huge bilateral reflux with the high creatinine. Then you can see both the kidneys are showing scarring. Severely dilated ureter, tortuous ureter. There again, you can see some damage to the kidney. And these are the certain very unusual anatomy. Here you can see extrophy, cross-produced ectopia with the bilateral reflux in both the unit, and then single kidney with the severe and tortuous ureter with the reflux. And here you can see right side the duplex system with the reflux in both the moiety. So these are the high-risk group and generally requires a procedure. And before I go to the polytenoloate better, let us start with the Cohen's cross-trigonal, because this procedure is favorite of most of us. And this is the critical steps. Transverse incision or phalangeal incision is preferred. Sheath is also open in the similar fashion, and these muscles are split in the midline, and the bladder is open vertically at the trigone. And then we have to push certain weight gauze pieces and to retract the dome, and bilateral also the both the wall retracted to bring the trigone as well as the base of the bladder just up, and it should be like a flat plate. And then comes the gradual dissection of ureter from the mucosa as well as from the little bit of amount of detrusor. There you can use blind as well as blunt as well as sharp dissection. These are the some detrusor connections which to be taken with the cautery, but taking care of not damaging the adventitia to avoid the bleeding. And then once both the ureters are dissected adequately, that is 4 to 5 centimeter, it should reach to the skin. In another way, you can say, and then this much of ureter goes actually we have to excise, and then they are taken into the cross trigonal, and now the right is facing left and left is facing right. So this is a small clip. I think this clip is not working. So not spending much time. Again, the feeding tube is to be inserted into the ureteric orifices. It is secured, and then subsequently, as I demonstrated into these photographs, dissection is to be done. And so what we can say about the Cohen's reimplant is that no extravesical act, so no chances of peritoneal or intestinal injury. New hiatus is not created, so no issues of narrowing or kinking. While doing the detrusor or AFI in Cohen's, we have to see that we are not too tightening the stitches in the detrusor around the ureteric orifice. So there should not be any obstruction or kinking at that level. But the only disadvantage is the future retrograde endourological procedures are difficult. We can do any kind of reimplantation, even if the tapering is required, it can be done with the Cohen's reimplant technique. Now coming to the polytenoloate better, it was published in 1958 by these two authors, polytenoloate better in Journal of Urology, and thereafter it became very much popular. But against the Cohen's, right now it is not that popular, maybe because of some complexities involved into this procedure. Initial 2 to 3 steps are similar till we dissect the ureter from the detrusor, and then next step that you can see here in the step 3, what exactly the description is that you have to stab the bladder at the posterior wall to create the new hiatus, which is superior to the original hiatus, and that's why this procedure is known as a suprahiatal technique. And then you have to go in extravesical space to bring the ureter back inside the bladder for the further tunneling and the reimplantation. So that, by contrast with other procedure, this extravesical act is not easy, and there remains fear of injury to the structures posterior to the bladder, like vas, peritoneum, or intestine, and sometimes we can come through the or reroute through the peritoneum, and that can be reason for some kinking or hinging. So there are always modification, and here there is a modification where which was published in 2006. They started using Langenbeck retractor at the original hiatus to lift the posterior bladder wall, and under vision push the peritoneum from this. So under vision it can be separated posterior bladder wall from the peritoneum. So here is a small clip. I hope this will run. This I wanted to show. Harpreet, can I go a little bit back and come again?
Please go ahead, sir.
Give me a minute, just.
Yeah, sure. Take your time. Thanks. So due to technical issue, we'll go to Dr. Ansari's presentation. Ansari sir, can you hear me?
Of course, sir.
Yeah, sir, are you ready? If you can start sharing your screen and start your presentation.
Okay, okay.
Right. Thank you, sir. Dr. Anil will come back to us. There's some technical issues.
Right. Not a problem. So, am I visible, sir? My presentation is visible?
Yes.
Not yet, sir.
Now?
No. Even team, audiovisual team. Yeah, now we can see your presentation. Clear.
Sir, it is visible, sir?
Yes, sir. Yes, sir.
Okay.
Welcome,
Thank
sir.
you.
Good morning, sir.
Good morning, Dr. Harper. And I thanks all the executives of the EZ-USICON and then especially Dr. Harper and the executive body and Dr. Takwani both.
Right.
So megaurator cannot be attributed to a particular entity because that may.
Dr. Ansari, can you on your video? You start your video is off. That's what my audiovisual team is saying.
Oh, yes. Let me try it.
Okay. Yeah.
So I will first come out.
Yeah. No.
Yes. Now I will start my video.
Yes, sir. Now we can see you, sir.
So, okay, I will share again. So going back to my slideshow. It visible, sir?
Not yet.
Now your Hannah, it
Yes,
has
sir.
to be
Yes,
connected
sir.
from.
We can
So-
see both your slides and you, sir. Thank you.
So megarotor cannot be attributed to a particular entity. We all know that this may exist with reflux, absence of reflux, in the setting of both, or in the absence of either. So it is just a dilatation of the ureter which can be found in many situations. And most of the cases in the Western world are diagnosed antenatally, and nearly more than 90%. And unfortunately, in India, our antenatal diagnosis is still low. The detection is nearly 30 to 40%, even the center who are doing high volume pediatric cases. The first investigation we all know, I will be touching only the salient and the debatable questions related to the mega-ureter, because many of the surgical steps will be similar between me and Dr. Takwani. So Dr. Takwani will be coming back with his videos, and there will be slight differences in the technical aspect in the planning that I will touch in my presentation. So in ultrasonography, we basically see the grade of hydronephrosis, and another point which is usually missed is the retrovesical ureteric diameter, because both have a connotation in terms of the follow-up of these cases on long-term basis. We can assess on observational policies, the grade of hydronephrosis is stable, decreasing, or increasing. Similarly, a retrovesical diameter, both in longitudinal as well as the transverse scan, has to be reported in both the directions, so that subsequently these parameters can be compared when we monitor these children. The functional assessment has to be done once the bladder outlet obstruction, the reflux are excluded. Babies with hydronephrosis or isolated ureteric dilatation, when it is more than 10 millimeter, to look for obstruction at PUG. And these are the recommendations both from the British Association of Pediatricology as well as European Society of Pediatricology. And the functional assessment, we all understand that it has to be done either through the DTPA scan or MAC3 scan. And the MAC3 scan has a superiority over a DTPA, while when we are going to assess the GFR, then the DTPA is better. We all know that the extraction fraction for MAC3 is better. It gives better visualization of the kidneys, as it is not secreted through the glomeruli, rather this is filtered and secreted by the renal tubules purely. But there are certain problems with this renal scan, because the interpretation of the renal scan is quite easier in cases of hydronephrosis secondary to UPG obstruction. But if it is a hydroureteronephrosis, there are many variables which are operator dependent, which might not be easy to interpret in cases of mega-ureter, whether this is obstructing, non-obstructing, or this is neither obstructing or non-refluxing. That is the most difficult situation to diagnose. This also depends on the tracer dosing, time of diuretic administration, patient hydration, and determination of the study areas of the interest, which most of the time the nuclear physicists, they focus on the UPJ, and they do not care much about the dilated ureter unless we specifically ask them. There may be regions where we may find false positive studies for obstruction, and we may overdiagnose these children. And these situations may be children under 3 months of age, as the tubules of the newborn show blunted response to diuretic, and these children have low baseline glomerular filtration rate. So there may be a unphysiological obstruction reported in these scans. Another is the dehydration and single kidney, which is having a low GFR under 15 ml of minute. So how can we avoid all these? We all know that it has to be done a well-tempered renogram as advised by the Pediatric Society of Nuclear Medicine. That it includes 3 important components. The child has to be properly hydrated with crystalloid, and Lasix has to be administered at the peak of tracer accumulation in the kidney. When it reaches to a certain plateau, this is the point when the Lasix has to be given. And child has to be catheterized prior to the study, so there is no secondary effect of the bladder or bladder outlet. Most of the time we diagnose obstruction on the basis of T-half, but we have to be little careful when we apply this rule to mega-ureter. because all these T-half have been developed by Aurelis in terms of the UPG obstruction. Why I say this? Because in cases of MAG ureter, if you see the picture on the right side, the compliance of the ureter, the capacity of the entire piece system, and the whole length of the ureter, which almost become 3 to 4 times sometimes to the original length of the ureter in a normal child. So it really becomes difficult to apply the same formula of 20 minutes to diagnose obstruction, as there may not be true obstruction because of the volume to which it takes a long time for the radio tracer to travel all through across the ureter and finally through the VUJ. So the T-half cannot be reliably applied to the cases of mega ureter when we are dealing in terms of VUJ obstruction. So this is a very important point. Now in these cases, that is why we say that is not only the T-half, but you see the function of the kidney, grade of the hydronephrosis, the dilatation of the ureter, especially in terms of the retrovascular ureteric diameter, which is taken in both the axis. Another test which has been done in difficult situation is the Whittaker test, which is not very popular in pediatric population because of its invasive nature, especially in cases when the system is super dilated. Again, the pressure may not rise to the desirable point of diagnosis of the Whittaker. So again, going back to the same situation that you have to rely both combination of renal scan as well as on the ultrasonographic criteria. And VCUG has to be done because, as I initially said, the mega ureter does not denote a specific entity. This may be primary, this may be secondary, and there may be a lot of long spectrum of secondary causes leading to the dilatation of the ureter. So VCUG is done with a plan to find out reflux and other secondary causes, because the treatment plan grossly differs in both primary as well as the secondary mega ureters. See, this is straight away case of primary mega ureter, which can be simply kept under observation with suppressive antibiotic. This second image, you see a mega ureter with lot of bladder changes. So this will need a different kind of planning for managing this child. This child, you see the two pictures with bladder diverticulum along with the mega ureter on the same side. This will also require another type of surgical planning. And these are the kids also will not respond to the conservative management also, because that is the commonest policy in mega ureter, which I will be dealing in my subsequent slides. MRI has specific roles in certain complex anatomical situations when the kidney is extraordinarily large as compared to the contralateral, or in regard to the age of the child or the baby, and when we are suspecting duplex system, unilateral or bilateral, or the child is coming with history of incontinence, that may also suggest an ectopic ureter or duplex system also, like we see in this. So in these situations, MR urography gives an important clue and helps in diagnosing further. Now coming to the management part, we have two types of approach, observational as well as surgical approach. And there may be an alternative approach which I have written as minimally invasive, and of to this, the attracting part is the double J stenting and the balloon dilatation, while the other minimally approach may be the laparoscopic and the robotic, which are not very popular, and many people of us are not familiar to these techniques. While the surgical approaches differs in cases of infancy and beyond infancy. In infancy, the options can be a temporary double J stent, refluxing reimplantation, or ureterostomy. And beyond infancy, we may try open surgery as well as all other options available for minimally invasive surgeries. So as I said, nearly 70 to 80% of the all mega ureters, they respond to the observational policy. And what is the rationale for this? When I say this, and this is the review of literature which I brought. If I present you this, the overall resolution in the various large series has been between the 42 to 93%. There is a wide gap of spontaneous resolution. Almost 40 to 90 is almost the double of this 40%, rather more than double. So there are some regions, but overall, if you see, when these kids have been specifically scrutinized in terms of this obstruction at VUJ while putting a catheter into the bladder, and the renal scan has been done as per the protocol of tempered renogram, and genuine obstruction has been defined as per the definition, then the chances of resolution of this spontaneity is less. That drops to the tune of 50%. When renal scans were not done, they were empirically kept on observation without confirming the definitive obstruction of the VUJ, then the resolution was to the tune of 90%. But overall, if you mix both the both together, where the renal scan was done to find out definitive obstruction at VUJ, as well as no renal scan was done with an intention to find out obstruction, when you combine both the cohort, then the average resolution rate is 60 to 70%. And I think that is a very substantial resolution rate in VUJ. In the same principle, you can apply to the antenatal head nephrosis attributed to UPJ obstruction. So the basic principle of follow-up, it has to be continuous monitoring. One need to be little judicious and careful, because the failures which can be slipped and remain undiagnosed because of the poor compliance in the follow-up. And it has to be very conscientious and honest follow-up on the part of both the treating urologists, pediatric urologists, and the family. And the most debatable question here is how long this baby has to be followed. As such, there is no consensus. Why I say? Because if you review the literature, the failure has been reported in Magaurator, where the complete resolution has been documented. After that 6 years, the failure has been reported. Failure has also been reported after the 14 years. So the generally, in cases of Magaurator, at least beyond 5 to 6 years, one scan has to be done, ultrasonographic scan, yearly until the age of 18 years. And these are the recommendations of the British Pediatric Urological Association, that at least we should have some kind of monitoring up to the 18 years of age. So this is a small summary of how this this natural course of the Magaurator goes. Nearly 2/3 they stabilize over a period of 2 to 2.5 years, 2.5 to 3 years. If you see here, the larger series which I've seen, most of these resolutions, they fall between 2.5 to 3 years. And these are the third which may remain stable or they may deteriorate. And there are regions who will deteriorate when there is underlying factors which basically control is the low grade of nephrosis leading to resolution, retrovasculated diameter less than 10, and the split renal function baseline greater than 40%. These are favorable factors where you can counsel the family that these are the factors in your baby, that there are high likelihood that the baby is going to resolve with time. While the predictors of the failure, obviously this is what I said, that the SFQ grading has to be recorded at the baseline 3 and 4, split renal function baseline less than 40, retrovasculated diameter more than 10, and type 3, the cases which complex reflux or the complex or the severe kinks and the curves and tortuosity on MR urography or voiding cystoarthrogram or ultrasonography, that also results into the failure of this spontaneous resolution, or the kids which are symptomatic, having recurrent UTI, failure to thrive or failure to accept feed, and children who are diagnosed postnatally. Usually the kids which are diagnosed with Magaurator antenatally, they do better as compared to the postnatal diagnosis. And when to intervene? When you review this European and this American, this British guidelines, when there is a deterioration of the split renal function by greater than 5% on 2 consequent scans, or there is a progressive dilatation of ureter as well as upper tract, or if the baby becomes symptomatic, symptoms of it, he feels unwell, recurrent fever, UTI, or any episode of pulmononephritis. So these are the factors when the child qualifies for the surgical intervention. And these are some differences between the management of non-obstructing versus obstructing Magaurator. As I said, most of the time this is conservative, and all kids especially under 1 year of age, they should receive prophylactic antibiotics. And this observation has to continue as long as renal function is not significantly affected, urinary infections are not there, then we can continue. If the child fails, suppose this failure may be even within 1 year, then when to operate? Typically, surgical repair is warranted between 1 to 2 years of age. Results are very bad if we are operating within 1 year. As I initially said, that in infancy, the options are different, because then ureterostomy are better, or refluxing vesicoureterostomy may be an option rather than going for the reimplantation. This is what I said, that if the child fails in infancy within 1 year of age of observational therapy, then it will be safer to do loop ureterostomy or a refluxing ureteric reimplant. What I mean that you simply disconnect the ureter just proximal to the tapering end and put it on the bladder, close to the dome. There is no need to create any kind of detrussorrhaphy or tunnel. Simple uretrovesicostomy, so that there is no obstruction stasis, and this will allow kidneys to drain. Or if the child is stable and the facilities are not available, if the BAPU has received, this British Pediatric Urological Association has advised, even the stent can be placed so that the child can be sailed through within the first year or infancy period. Then after infancy, surgery can be done, or the baby can be referred to a center where the facilities for the reimplantation are available. Emergency intervention: if the child is toxic, septic, a percutaneous nephrostomy for a short period of time can be done, and after that, when the baby becomes stable, can be converted to a cutaneous ureterostomy in the form of loop ureterostomy or end ureterostomy. Now, coming to the basic surgical options, the surgical steps will be seen by Dr. Takwani, as spoken to him. The basic principle basically involve the ureteral tending, which is usually necessary to achieve the proper length to diameter ratio, that is 4 to 5:1. And narrowing of the ureter may enable the walls of coaptation, leading to more effective peristalsis to move the urinary bolus. There should be excision of the distal adynamic segment. Kinking, usually seen in almost all child with mega ureter and are not so noxious. They can be ignored unless they are massive tortuosity and dilatation. Then only the lower kinks can be straightened. Extensive tailoring of the ureter has to be avoided, because there is a risk of ischemia. Now, how to choose a technique? There is an intravesical, combined and extravesical technique. What I simply follow the algorithm through which I may plan before these kits are taken on the surgery. If I have a retrovesical ureteric diameter, if it is not done, it can be done at the time before the surgery. If it is up to 15 millimeter, then we can safely go through the intravesical route. If we go for combined, that the child, you may need intravesical, means that you may strictly go for the coherent implantation, which is commonly practiced across the world. While in cases when the retrovesical ureteric diameter is more than 15 millimeter, there are a lot of kinks in the curves. You see that there may be a secondary obstruction in spite of my reimplantation being excellent. You are fearing that you may require internal dissection followed by some dissection outside the bladder, and redo surgeries which may require tailoring, tapering, or there may be a straight pathology like ectopic ureter. You have no other option except going outside the bladder and coming back to the bladder. Diverticulum or stones associated, which I will be showing some of the interesting cases subsequently. Extravesical approach is usually discouraged in children. There are certain specific conditions where we may go for the extravesical approach also. So, coming to the three debatable questions: tapering, how much tapering has to be done? Then site of tapering, medial or lateral, again debatable, a contentious issue, and the type of tapering. Coming to one by one, how much tapering has to be done? The simple rule which I follow is the vesicle plus additional 2 to 3 centimeter. Sometimes the length of the ureter is so enormous that almost 10 to 15 centimeter of the ureter comes out after the dissection. You keep on dissection in a hope that the ureter will get straightened. But you need not to straighten taper all the ureter, only this much part in the intravesical, this much part, along with additional 2 to 3 centimeter you have to take. Distal part you are invariably you exercise because of it is adynamic, and secondly because of the handling of the tissue it also become traumatized and ischemic. Changes are there. While how much this tapering has to be done before toilet train, it should not be less than 10 French, and after toilet train in adolescent and adults this should not be less than 10 French to avoid any ischemic and the stenosis. Site of tapering, another contentious issue. If you see this image, you see that the blood supply to the ureter comes, lower part of the ureter, which is the area of intention here, comes from the lateral side. But if you see this, once the ureter is dissected all around and hanging freely, then the medial or lateral blood supply does not matter. But what matters is the blood supply which runs through the under adventitia and the submucosal plate. So once this ureter is free lying in the hand of the surgeon, where from the question of medial or lateral comes. It's still how to do, then it does not matter whether the blood supply is coming from medial or lateral. Then the choice depends on the surgeon where to make ureterotomy, medial or lateral. So how to decide this? This. Then you have a choice. You can modify, because if you do this ureterotomy on the posterior side, so what will happen? This will give the advantage when you take the ureter into the tunnel, the suture line will fall back on the detrusor muscle. So the chances of fistula and the bladder will minimize. The chances of recurrence of the reflux will be minimum. If you make this ureterotomy anteriorly or laterally, it means this ureterotomy is medial. Suture line will be medial. Once you go, this ureter goes into the tunnel, this will fall back against the detrusor and will be suppressed. This will compress in the ureter, this mucosa. So the chances of this dehiscence and fistula formation, recurrence of the reflux will be further minimized. So the tapering can be safely done on the medial, so that this suits to the surgeon also to prevent the post-operative fistula also. And this mouth
Our connection is okay, event team? Okay. Yeah, Anil sir.
Delegates, we are very sorry, though we are doing this kind of work or so quite often. Today we are facing bit difficulty. So what you want, Harpreet, should I start from where I have left, or we wait for Dr. Ansari?
Yes, sir. Please start.
So is he sharing the screen or no?
No, we are not seeing your screen, sir.
Host has to again enable me. Dr. Ansari, would you like to start again? Sir, unmute yourself, sir.
Just 2 to 3 slides only.
Yeah, please go ahead,
Okay,
sir.
so
if Ansari sir is ready, we'd like to conclude his session.
Yes.
Yes,
Sure.
yes.
Go ahead.
Okay.
Okay, right, great.
Just 2 to 3 slides.
No,
only.
sir, go ahead.
Please go ahead, sir.
Okay, so I am visible there?
Yes,
No,
sir.
sir.
No?
At least I am seeing this slide as well as Dr. Ansari.
Yeah, now you're
Okay,
visible
okay,
and we
so-
see your screen also.
Okay, right, sir. So I will just how to decide the excisional and the non-excisional tapering. Simple rule is that it has been seen in some of the literature. If the ureteric diameter is more than 8 centimeter, then you have to go for the less than 1.8 centimeter, you may try that and defaulting of the plication. The two techniques which are seen here. If it is more than that, then the ureter becomes too bulky. It will not be easy to take it across the submucosal tunnel. Chances of stenosis, ischemia, as well as obstruction will be higher. So this is a simple rule. We can try excisional and the non-excisional techniques. Hand drain is simple to do it, and both Helsinki and the Ester are difficult. So what may follow this rule when to use these two techniques? So these are some special scenarios where you may find a MAGA-ureter with ureteric stones. You may go for ureterotomy, extravesical, then converting into the intravesical way. And MAGA-ureter with bladder diverticulum, where you may need the combination both intravesical, but those who are doing diverticulum regularly, this diverticulum and MAGA-ureter can be done purely intravesically, but the diverticulum can be excised intravesically as followed by reimplantation. The choice is yours whether you go for Cohen or the Politano. My choice is usually Cohen. Simply in cases of MAGA-ureter with duplex system, the simple rule is that you disconnect the dilated ureter and fix it to the narrow. The normal ureter is the recipient ureter, and the dilated ureter has to go as a donor ureter to the non-dilated system. Ipsilateral ureterostomy or immune ureteropilostomy can be done, but ureterostomy is simpler at the level of iliac crest, which can be simply done. Ureteropilostomy is always difficult, more chances of stenosis and blood ischemic loss. Similarly, you may get this ureterocele. See here the filling defect, almost hundreds or thousands of stones here. You may try the same principle. You may give an incision of this histolitholapaxy, clear all the stones for this ureterocele, and you may go for iliac crest level, this ureterostomy. For minimally invasive, I just quickly through. These are the balloon dilatation, which have been effective in certain series. Short stenotic strictures, less than 5 millimeter. It has given excellent results, intermediate results in 5 to 1 centimeter. And now the studies are available for intermediate follow-up of 7 to 10 years with overall success rate of 67 to 95, depending on the size, this length of the adynamic segment. And the advantage we all know, if by chance this balloon dilatation fails, there is which baby can be taken anytime for the reimplantation. And similarly, ureterotomy has also been tried in these cases. This is the same acute-size balloon cutter which is used for endopalatomy. It has also given some 70 to 80% results on reasonably 7 to 10 years of follow-up. And with this, I thank you, all executives and Dr. Harpada Takwani for giving me this opportunity.
Excellent presentation, Ansari sir. This house is open for questions. Sir, I have one question. As per your talk, is that only majority of the treatment in primary obstructive MAGA-ureter is conservative? Only few percentage of...
Yes, sir. Only few percentage, 70 to 80%, they will resolve with time. And I say simply have a baseline ultrasonography for grade of hydronephrosis and the retrovesical ureteric diameter. Just monitor it. Do not rely too much on renal scan. I think Dr. Takwani and Dr. Malik will agree with this, because ultrasonography itself will give lot of information, because renal scan has says enormously dilated kidney in MAGA-ureter is so dubious and will lead you to the area where you will not be in a position to counsel families.
Dr. Ansari, and you have mentioned about antibiotics, that you should continue antibiotics. So how long you want to continue antibiotics?
Yes, it is a rule. All infants has to be continued with any obstructing or refluxive system. These are the guidelines. And especially under 1 year of age. Especially you have to give to 1 year, but in Indian scenario, if you see the guidelines, up to 2 years we recommend.
Okay, sir.
Dr. Ansari, during reimplantation, do you routinely do the submucosal tunneling or simply doing the nippling of the ureter?
I prefer this submucosal tunneling because nippling sometimes is not possible, and nippling has sometimes resulted into the obstruction also. Though people have tried in adult cases, nippling is successful, but the size of the ureter is small. In children, nippling is not that effective. Ischemia obstruction is common. In adult, I agree nippling is effective. Even if reflux persists, doesn't matter much.
Dr. Ansari, Dr. Chatterjee from Calcutta.
Right,
One thing,
sir. Mhm.
Dr. Chatterjee.
Yeah, Dr. Uday, please go ahead.
Yes. One thing, everything you have mentioned, but one thing I don't know whether you prefer or not. There is the aerodynamic study to exclude the bladder pressure is present or not, particularly before operation and during follow-up, when you are expecting that there will be spontaneous resolution. But whether it is better to eliminate the bladder pressure or not, particularly in the refluxing pump.
So, say it is not a routine to practice. It is, if you ask me, all cases of failed mega ureter or this refluxing, then aerodynamics is recommended because before you go for the second bout of the surgery. But in cases of primary mega ureter or primary refluxing mega ureter, unless you doubt on VCUG has been done, you find some abnormality in the bladder or there are definitive symptoms in the child, in toilet trained child, that there may be some bladder dysfunction in terms of incontinence, bedwetting, or this symptoms suggestive of overactive, then the aerodynamics suggested. Otherwise, in isolated case of mega-ureter or refluxing mega-ureter, whether it is obstructing or refluxing, aerodynamics is not recommended. It is considered to be highly invasive in such situations.
Any other questions from the house?
Can I have a word?
Yes, Dr. Anil.
This year, all pediatric urologists of the Urological Society of India collectively decided to spread the message against the radiation, excess radiation in the pediatric urology practice. And so I would like to enforce the statement done by the Dr. Ansari that all these cases of suspected obstruction can be really followed by the serial sonography. Only thing is that we have to trust that single sonologist who is become expert like you, so we can avoid the repeated voiding cystoscopy as well as scan in the cases of reflux, as well as the repeated diuretic scans in the cases of obstruction. So please, this is the message which we wanted to convey, and we got this today platform for that. Dr. Ansari, I have one last question. What is your preference? You fold or you excise while tapering? What is your personal preference?
Then I follow the rule. This one, if it is up to 1.8 to 2 centimeter, if it is beyond that, I always go for this excisional tapering. And you will believe me that this is just a coincidence that majority of the ureters is so dilated because I follow observational policies. Similarly, in antenatal head nephrosis, when I go for this pyeloplasty, most of the APDs are 3 centimeter, 4 centimeter, 5 centimeter. This is by default I am getting the ureters because of my observational policies. They are hugely, enormously dilated. So Hendron is my first preference. In certain cases, I have tried plication.
So same is here, sir.
A question, Dr. Anil and Dr. Ansari both. Where you do the tapering and actually the excision and you reimplant, are you if you're following your patient with maybe 6 months or 1 year, whatever your policy for MCUG, do you see there the patients who are actually having reflux after your surgery and the patients which you have reimplanted without tapering are not having reflux? Your comments, please.
No.
Any difference in that?
No, but Harpreet, if the ureter is excessively dilated, you have to go for a tapering. And if you do a successful tapering as described by the mentioned by the Dr. Ansari, and the most important tip is that your suture line should fall in with the detrusor rather than the anteriorly. So that is the point of technique for the tapering. And if you follow this, what he has described, I think there is no reason of having a MCU showing the reflux, or later on the drainage study shows the obstruction. And I agree with him except that you need to taper only last 5 to 7 centimeter of the ureter. And to our surprise, if you follow this patient after 6 months or a year, the rest of the ureter appears to be absolutely straightened in the drainage study.
Dr. Harper's question is, what he says, when you do tapering, persistent reflux is more common. When you do not do tapering, chances of persistent reflux is less. Is that Dr. Harper?
Yes, sir. Exactly.
Yeah, exactly. So this is a very interesting phenomena. When we started all this anti-reflux surgery, this is a common phenomena of occurrence. And really thank you for this observation. So the main problem is that because of apprehension that there should not be any stenosis or ischemia, we keep the tube bigger, wider. But if I say that you stick to the rule of 10 and stick to the rule of 8 under toilet 10 and outside the toilet 10, this is not going to, because if you are keeping this this tube larger than 10, if the child is about 3 years, then we cannot maintain the ratio of minimum 4:1. That is the reason of I realized, because I burned my finger so many times, then I realized no need not to worry. I have to be 10, not more than 10, even if it is a 15-year-old boy.
So bit exaggerated tunnel is preferred whenever
yes,
we have
that is why.
Thank you, Ansari sir. Thank you.
Can I ask one last question?
Yeah, Gopal, please.
There is a question to Dr. Takwani as well as Dr. Ansari. The message from both of you is pretty clear that for infants, open reimplantation is the gold standard. Why is then robotic reimplantation being promoted gradually? And do you think it will become a gold standard in future, and in what way?
You will take Dr. Mandani this question, or should I?
Yeah, I see the videos.
Dr. Ansari, you take.
Okay.
Because
this
you
is
are doing all those things, and Malik is also doing.
See, I did not touch laparoscopic ureteric reimplantation. I did not touch this robotic transplantation. We have done nearly over 50 laparoscopic, almost 35 robotic also. I did not touch it because that is not a standard of care still in terms of reimplantation. And I fully agree that still the gold standard remains the open surgery. What is the future of minimally invasive surgery? Has this minimally invasive surgery in terms of laparoscopy or robotic is still in the phase of evaluation. So whenever I present my robotic reimplantation, people ask what is the rationale of this. I say this is under this technology is still under the phase of evaluation, and this reimplantation right now is in the same phase as in 98, 96. The laparoscopic radical nephrectomy was being criticized so much. Now this has become the standard of care. Maybe the time will come when the science will realize that robot and the laparoscopy has become the standard of care. And for robotic, I will still say this is a maximal application of minimally invasive surgery right now in urology. We do not have such a small space transvasically going and doing reimplantation. This is the maximal application or minimal invasive surgery.
Dr.
Right
Ansari, I would like to add one more additional question into that. Do you think
please
that
go.
while in laparoscopic or robotic intravesical technique, do you feel that there is too much of lower ureteric manipulation, and that is the reason that probably you don't like, or you have some other reasons of not?
No. This is more exhaustive and tiring in this because your working elements are most of the time is vertical. So
in robotic, you have no issues with the exhaust and.
But in robotic, yes, time will tell whether robotic becomes the gold standard. There is no fatigue at all.
Do you think that too much of lower ureteric manipulation in compared to the open techniques?
No. Usually with you have little bit experience, you get, although you do not get any tactile stimulation in robot, but with little experience and learning curve, you all learn how to handle tissue. Because if we apply this, people are doing robotic renal transplantation, renal artery, renal vein, which much delicate than ureter.
So message is clear. Yes,
All learned by
the open
experience.
is the gold standard. And with this, we move
Yes,
forward.
open
Thank you, Dr. Ansari sir, for joining us in the early morning on Sunday.
Arpit, with your
and enlightening
permission,
us.
I am going ahead with the couple of video clips only.
Yes, sir.
To just finish it quickly. Let me try if it runs.
Yes, sir, please.
Yeah, yeah. So, it's running. Yeah. So this is what exactly we do. We insert the feeding tubes and then fix it with a stay to secure it, and then circumferential incision. There is a different techniques for this. Somebody pull it and then this is very important. What Dr. Ansari also told is that you have to do some sharp and blunt dissection, as well as we have to use cautery at times. And while we use cautery, we have to see that we doesn't disturb the integrity of the adventitia, because most of this vascularity of the distal ureter now depends on the vessels running under the adventitial layer. So we have to see, and this is another step I wanted to show is the detrussorography. So to do a perfect detrussorography, but see that we don't in coins, we don't narrow the ureteric hiatus, which is an original hiatus, but which is got broadened because of our dissection. But we have to check, and then similar procedure on opposite side. And next step is the tunnel formation, and we have to bring the ureter cross trigonal. Right will go on the left will go on the right. Only thing is the more dilated one generally remains on the upper side, so it gets little more tunnel. That is what the question for the PGs many of the time. So let us move. This is we have already talked. So here I was telling that this extravesical egg, which is involved into the polynoidal better, make it different from the other technique, that is the Cohen's technique. And for that, this modification came retracting with the Langenbeck retractor. And this is the small video clip. This is the after classical intravesical dissection of the ureter. We have to plan the neo hiatus, which is 4 to 5 centimeters superior and bit lateral to the original hiatus, and then lift the posterior bladder wall either with a stay or with the blunt object, and then push the peritoneum away from the bladder wall, posterior bladder wall under vision, and there you can see 4 to 5 centimeter area, there is nothing, and then you can push the right angle along with the stay and make a new hiatus, and then the tunnel is formed this much almost, and this is a stitch over the neo mucosa, the neo hiatus, to bury that neo hiatus. There you can see almost this much of tunnel, 2.5 centimeter tunnel achieved, that is proximal tunnel, and rest of the tunnel will be achieved after the detrussorography. So again, here we have to spare the mucosa, and we have to suture the detrussor, approximate the detrussor with the help of 4O Vicryl. Even people are using 3O Vicryl, couple of stitches to approximate the detrussor, leaving the mucosa for distal tunnel formation. And this is very important aspect. So there you can see another tunnel is added. So almost it is 4 to 4.5 centimeter of tunnel right from here to ureteric opening. And then this is the last step where ureteric edge sutured with the bladder mucosa, which is absolutely at the orthotopic in position. So by chance, suppose in a center like me, where urolithiasis is very common, and as I'm now practicing since last 22 years, I'm seeing a couple of cases that do come with the urolithiasis, need to retrograde. So after this anastomosis, you have to check the patency with the feeding tube. It should go easily without any resistance, and there you can see urine drop. You can pull out the feeding tube, and generally in this case, we don't keep the stent even. So this is the similar modified procedure can be done for the duplex system. Here you can see a duplex system with the common stem and both the dilated ureter. This part is going to be excised, what is very important is in male patients that we have to look for this vast difference. And once we identify it, don't handle it directly, just push it more and more distally along with the peritoneum for the couple of centimeter. And then the similar kind of this modified kind of a dissection between the peritoneum and the posterior bladder wall can be done. But here the detrusor gap will be much higher, so we have to take care that we do a proper detrusorraphy again. So this is another clip, short clip of the bilateral this modification of polytenon leadbetter. I was used to do Cohen's for a number of years, but since last 2 to 3 years, I shifted to this modified polytenon leadbetter, and I see that there is no now fear with this modification. Initial dissections like we do in a Gilvernet dissection with the gauze, when the space is created, we have to dissect further peritoneum away from the posterior wall. Posterior wall is lifted with the stay, and then you do this dissection, blunt dissection of peritoneum almost 4 to 5 centimeter. So peritoneum is shifted into the limited area away from the posterior bladder wall. And there are other modifications. For example, a couple of people are cutting the mucosa along with the detrusor. We feel it is more traumatic. And there under vision, you can push the right angle, and that is 4 to 5 centimeter above the original hiatus. And with the railroading technique, you can bring another right angle from the original hiatus, and then you catch the stay stitch and reroute the ureter inside the bladder. A good length of the ureter can be brought inside, and then this is the last step of forming the tunnel between the mucosa and detrusor, which generally comes easily in cases of primary vesicular reflux cases. Very important, as Dr. Ansari said, that you have to preserve the adventitia. And this is the last step, tunnel, and then fixing the ureter at the absolutely in orthotopic position. So this works in my hand, 32 procedure in last 2 years with 100% success, no blind dissection in the extravesical act. So no chances of injuries to vas, peritoneum, and bowel. Not seen any neuropraxia in both of these procedure, Cohen's as well as polytenon leadbetter, long duration catheter for retention of urine, and stents only if tapering or difficult dissection of ureter, initial dissection. No suprapubic tube or drain as described in original polytenon leadbetter in 1958. So only PUC, that is only for 4 to 5 days, and patient generally gets discharged within 36 to 48 hours. So this modification is easy, effective, and easily reproducible. Thank you very much once again for listening with patience, and sorry for this inconvenience. Thank you very much.
Excellent demonstration, Anil sir. Very nice. We are able to see both the techniques of Cohen's and leadbetter, even the modified one. You don't use saline or for the submucosal tunnel, right? You go directly. Or
generally, in cases of primary vesicular reflux, we do not need to do all those things because bladder remains normal in primary vesicular reflux patients in most of the cases, except those who have a little bit of voiding dysfunction. But it gets separated most of the time very easy with the help of Caesar. Are you able to see me?
Hello?
Harpreet?
Yes, sir.
Am I seen?
Yeah, you are seen, sir.
Okay, fine.
Since we are running short of time, can you
Sure.
go to the last
We have a lot of questions. So thank you very much once again, Eastern Council, for this opportunity to all of us, and go ahead with the next presentation of Dr. Malika, please.
Yeah.
Thank you.
Thank you, sir. Thank you, Anil sir. Dr. Mali?
Yeah.
Yeah, right, sir. Thank you, sir.
Yeah. Seeing the screen now?
No, sir, not yet.
Your guys have to put it up, I think.
Yeah, now we see, sir.
Yeah.
Welcome, sir. Good morning, sir.
Thank you, Harpreet. Thank you, Dr. Ranjan, and thank you, EZ-USICON, for this opportunity. And then thanks, Anil, to getting us all together again after a fair bit of time. So I probably would not really go much on to the very principles of diagnosis of PUJ and conservative management. I would just stick to the minimal invasive pyeloplasty and a little small modifications, which would probably make our life much easier. So the general principles when you do this procedure is you need to know how to put your ports and exactly where to put your ports. You need to know your instruments, that what will a Maryland do, what will your suction do, what will your, like if you want to use a suction, you can use it for suction, you can use it for putting your stent. So in such a way, you need to know your instruments, and you have to place the instruments in relation to the organ where you need to do the anastomosis. So if you have a instrument which is parallel, that is fine, because the needle will become 90 degrees. And if you have the instrument which is 90 degrees, your needle will come parallel to the tissue, then you will not be able to do the pyeloplasty. So plan your approach, whether you want to do a retroperitoneal, transperitoneal, transmesocholic. Utilize the anatomy to our advantage. I'll come to that point, and then create your own reference points inside, because there are no reference points like when you do an open surgery. So what I would try to show you is, when do you opt for a transmesocholic approach? How do you handle the ureter? How do you handle the pelvis? The little part of stenting and the hitch stitch. How do you use the hitch stitch? So what we do is the standard position, and then we actually pad this kid so that there is no hypothermia. What I would like to show you exactly is that bottle, a small bottle below in the flank, is generally not needed. I just wantonly put it so that people should not use it, because the abdomen is so small that the intestines will come and then obscure a view on the of the pelvis on either side of the kidney. So please don't use that. Just put a flank position. That should be absolutely fine. So this is a small video where actually what I do is I don't put ports. So you need to go exactly 90 degrees straight with the 11 needle, and then you go till the shaft. Then that you'll take the 3 mm instrument. The big advantage here is that you will be able to go through, take the needle, and then see, I'll show you how the needle would go through, and needle comes out. Now this is a big advantage, is any kind of needle right from 6-0 to 2-0 can go in and then come out. The important thing is you need to go exactly 90 degrees to the skin. So if you have an angulation, your exchange of instrument becomes very difficult. Now I'll show you how you need to hold the needle. So you need to hold the tip of the needle so that the tip doesn't project outside, and don't get the swathe end of the needle hitting the shaft of the instrument. So it will just go in easily. And then when you would like to get it out, you just be able to pull it out very comfortably. Okay. So what this does is it helps us in the ingress and egress of the needles without any issues, because these ports sometimes would actually bend the tip of the needle, and if they stay inside the ports, that becomes a difficult thing, and they are extremely cosmetic. So now let me look at to tell you when would you do a transmesocholic. Now when you see that you can put the colon away without any retraction. Now if you need a retraction onto the colon, and then you need to hold the colon with another port, all that then becomes difficult to do a transmesocholic. The second thing is you should be able to see the pelvis through this mesocolon. And there should be enough space for you to go ahead. You're able to see the kidney, the colon is sitting right on the lateral edge of the kidney. This is an ideal case to do a transmesocholic. People who are experienced can actually go through and do whatever way they would like. But that is important, that if your colon is sitting very medially on the renal pelvis, and then you want to retract the colon and do a transmesocholic, it may not be appropriate. Now, usage of suture, generally people would use a 4-0 or a 5-0. I would probably prefer a 5-0 or a 6-0. As you go on doing your work, you probably will become smaller on the sutures. And what I would do generally is I would not take the suture right onto the edge of the, you see that it is a little away from the edge. Now, what that does is it actually gives you a lot of leverage to do your suturing, and even if you have a little tug on the suture, you would not tear the ureter. In case there is a little difficult anastomosis to do, and then you have a tear, that becomes a difficult. And the second thing is the stent goes in much simpler, because if you have an edge suture, you will not see the opening of the ureter, and that is difficult to place the stent. But once you see the edge, it is absolutely fine. The next important thing is when you take the suture, the edge now, you already have a knot. you just have to go across the angle, and that is you have no knot on the angle, and this is much comfortable to suture. And post this modification, I haven't had any issues with the anastomosis because you are very comfortable with the angle. The other thing is I would definitely close a transmesocolon because once bitten, twice shy. I had a small intestinal obstruction in a 6-month-old child where the intestine went through the transmesocolon window, and then we ended up opening and then doing the intestinal obstruction. Now, as far as the hitch stitch is concerned, sometimes now the previous case you wouldn't have seen a hitch stitch being taken. That was because the ureter was lying lateral. Now, this was actually a little.
I'm having trouble hearing you.
Huh? Should be able to hear me.
Go ahead. You're nicely audible.
Go ahead. It is going perfect, Malik.
Okay. Yeah. Okay. The whole issue is this: the ureter and pelvis. The anatomy is slightly onto the posterior side. Now, when I started doing pyeloplasties way back in 2001, I always thought that a pyeloplasty is just to cut the ureter and put it back to the pelvis. Keep doing more and more. Every anatomy of the pelvis and ureter looks a little different, and you almost always have to think how to reconstruct the anatomy properly. Now you can see that this is a little posterior. The anatomy was a little posterior, so we had to put a hitch stitch to pick it up so that you get the proper anatomy. Now, I always now these days don't take a corner stitch, so because that's much easier to continue the anastomosis. And then the simplest thing is, as far as possible, I would not really like to hold much. There are a lot of people who say yes or no on this particular issue, but as far as possible, limit your handling of the tissues. The second important thing is when you have a handle of this pelvis here, which I don't have, but when you don't have a hitch stitch, you have a handle of the pelvis. Don't cut it till you finish the anastomosis or you are almost at the completion of your anastomosis, because you don't need to handle the area of anastomosis. You can just hold that tissue, you can move around the pelvis, do whatever you want, and then at the end, you can just cut it off. As far as possible, don't try to hold the mucosa, just the little adventitia, that would help you. A lot of small tricks. Now, what these things is, maybe it won't make much of a difference initially, but once you start doing the numbers, then you would realize that these small things make a difference, because even one failure is not acceptable. Now, that tissue would slowly go off, so we are not worried about that part of it. And then you can see a nice anastomosis at the end. Now you can see that the anatomy is now maintained. Now, the moment I cut, it will fall, and then the ureter will be right medial to the pelvis. Now, the another important thing is, a lot of times you see a malrotated kidney with a posteriorly placed pelvis. Now, just showing a robotic video, not that we've done enough laparoscopically. We just started doing our robotic work for the last 7 months now, 7-8 months now. But this is a very common scenario where the kidney is just sitting on the pelvis. Now, how do you reconstruct this anatomy? It's much more difficult. You use multiple ports, you pick up the kidney. How do you do the pyeloplasty? Get the proper orientation in. The simplest way is to get your lower pole up. Now you can see a nice narrowed segment, and then you do the anastomosis. You see this part of the ureter which we are looking at, that we are holding, and that will be cut because that's a part of the pelvis. So when we do the anastomosis, utilize the anatomy to your advantage. Keep a tissue which you would cut to handle the normal tissue which you would like to anastomose. Now you can see a nice anastomosis, nice wide anastomosis. And then most important thing is, don't ever pull your suture out. Sometimes we have a tendency to save a little money, and then we think that we can pull the suture out. I did once. I tore the lower pole of the kidney. I had to suture the lower pole of the kidney. So please don't do that. Always cut the suture, even if you have more suture. Now I just want to show you one more pyeloplasty. Only thing is, there's not much difference in terms of doing a laparoscopic versus robotic, but if you have the gadgets, probably you would do it. And then it's like adapting to the new technologies. I was a little averse initially, but once I had the robot, I realized that life is a little more easier doing this. Now, how much would you give a better result? No one knows, because already pyeloplasty has got one of the best results for any reconstructive surgery in urology. So, but it looks very nice. You can see a nice, beautiful signature on that, unlike in a laparoscopy where you will have a little ragged edge here and there. So this was our pyeloplasty chapter way back in 2015 in Urology Clinics of North America, and we had our own share of publications way back in 2005. So with this little thing, thank you again, EZ-USICON, for the audience. Any questions, I would be happy to take.
Thank you, sir, for an excellent presentation. It is a really very illustrative as well as looks excellent and very easy in your hand. The house is open for the question answers.
I know a lot of people would be doing pyeloplasties, but the only issue would be that you need to realize that anatomy of the pelvis and ureter is not the same always. So definitely you need to get it into the right place. Otherwise, we would have a
Malik, I would like to ask one question if the audience is not asking.
Yeah.
If you don't mind. I've seen your anastomosis in the lower pelvis and the upper pelvis. So there is a significant amount of pelvic wall is still remain on the lower side. So what do you think? This is all right, or you have to go as much as low possible to have a most dependent anastomosis?
No. When we do the anastomosis, we make sure that the anastomosis is dependent. A lot of times, if you see my hand, if there is a cup-like pelvis, you actually do a transverse cut and then open this. If you don't do this, you will end up in a high riding ureter. I haven't shown that video, but and most of the time when you have a high riding ureter, when you are correcting that, and that too in a horseshoe kidney, these are the issues. In a horseshoe kidney, because of the high riding ureter, you end up in when you cut, you end up in a cut. So you have to give a transverse cut and get a flap down, and then that flaps gets onto the ureter. Otherwise, you will end up in a high riding ureter with a suboptimal result. Horseshoe is a totally different kettle of fish.
Very difficult.
Hello.
Yes, sir.
One thing, have you ever tried non-dismembered pyeloplasty laparoscopically?
Of course, many a times.
Non-dismembered?
Yes, I'm talking about non-dismembered.
That is the Scardino-Prince or
polystyrene? Yes, Scardino-Prince once I had to do because of a long stricture. But most of the non-dismembered would be YV or a Heinke-Mikulicz. Heinke-Mikulicz also works, provided it's a very short and a small pelvis, short segment and a small pelvis. But most of the time in a non-dismembered, we would like to do this YV. But the important thing in YV is that you have to suture the wall which is away from you first. If you suture the wall which is towards you first, it would be much difficult to suture. And then don't put a stent initially. If you put a stent, it will keep coming in your suture. So do one wall, put the stent in a YV, and then do the opposite wall. And don't try to bring both the sutures. You have to tie the sutures both sides separately.
Are you comfortable in both situations, in non-dismembered and dismembered?
Whatever situation we are very easy. No, either one is not. Look, once you get experienced in doing things, there is nothing easy or nothing difficult. It is which is appropriate which goes in. Now you need to know how to do that appropriately. Unlike in a dismembered where you can bring both the sutures up at one corner and then tie them, knot them at one place. In a non-dismembered, you will have to tie these sutures individually. If you have a very short suture, take one more extra suture and then do a proper knotting. That is what makes the whole difference.
On behalf of East Zone urologists, I thank all three of you for giving us an insight into pediatric urology. Regards from all of us. Thank you, sir.
Thank you. Thank you.
Thank you. Thank you very much.
Thank you.
Hand over the mic to Shyam Babu for further next workshop.
Arpit, on behalf of entire team, I'm expressing our sorry for some inconvenience.
No, nothing, sir. It was really a pleasure. You have really introduced the subject very well. All of you have demonstrated very nicely. In fact, organizers wanted you all to felicitate all of you, but unfortunately you are so far. So we are sending you greetings and a lot of applause from all of us. Thank you, sir. Thank you for joining.
Thank you, everyone. Good morning. We are going to start the next session, the semi-live workshop that is on the andrology. May I call Dr. Sanjay Pandey on the dais, who is the faculty, is going to present the andrology videos on the different subjects. Can I call our chairperson, Dr. K. Pradhan? Please come on the dais, sir. Dr. R.V. Sabnis, sir, please come on dais. Dr. Sinam, sir, Rajendra Singh Sinam, sir, is not here. Okay, sir. Now, first I introduce the Dr. Sanjay Pandey. He is Dr. Sivaji Basu, sir, is here. Sir, please come on the dais and chair the session, sir. Dr. Sanjay Pandey, born in East Zone, Odisha, belongs to the North Zone, UP, trained in South Zone in Tamil Nadu and working in the West Zone, Maharashtra. This is his now at present head of the Department of the Andrology and Reconstructive Urology and the Robotic and Gender Assignment Surgery at Kokilaban Hospital, Mumbai. He is going to show a series of small videos on the tips and tricks on the subject on the Peyronie's disease, gender assignment, as well as the penile prosthesis surgery for the ED. Thank you, sir. With that, I can request Dr. Sanjay Pandey will present the case.
Respected Mr. Secretary, Dr. Shyam Babu, thank you for thinking out of the box to have made this as the last session. I've only got one disclosure to make, and that is to salute all my teachers, starting from my first teacher, Dr. Sudhir Raval in 1997, to Dr. Sunil Shroff and Dr. Dore Rajan and Dr. Santosh Kumar and Dr. Ganesh Gopalakrishnan and Dr. Nayan, Dr. Nitin, Dr. Pandey, Dr. Bijoy Abraham. So they have enthused us to such levels that when I came to Mumbai 13 years ago, Dr. Rupin Shah, Dr. Jackie Lal Malani, they have continuously given us that insight to move this subject forward. Without ado, I've attempted to actually bring in some videos which would enthuse a lot of our students in the audience and would give insights to a subject that could come forward. Thank you, Anil Takwani, Dr. Tariq, Dr. Ansari, and Dr. Mallikarjun for having given us the pediatric look to what actually could be the future. But today we're dealing with the real men, and these men matter. I've attempted to coalesce all that, so apologize the kind of mix-up which I've created for you. Every life matters is what they say at the Kokelaben Hospital, and that is what we all follow as motto as clinicians out there. Though we are so low down in the alphabetical order, dial U for urology. I carry greetings from Kokelaben Hospital and team urology, where Dr. Ismail and Dr. Bijoy happen to be colleagues, and the entire team helps us to move out. What got us here would never get us there. EZ-USICON USI today is an amazing kind of a feat. Dr. Ranjan Da and the entire team out here has done a wonderful job. It feels good and emotional to be playing as the last batsman today. We heard Dr. Mallikarjun speak today on this important aspect of how we'll practice tomorrow. But what got us here and will get us there is the way we continue to think and how doctors think. First Do No Harm is a book to be read by all of us. 13 years ago, when I came to Mumbai from Chennai, I had miles to go and had to think out of the box because I continue to do all. I was not a laparoscopic surgeon. I trained in andrology in a big way and reconstructive, and I was looking at the modern diseases which actually were bringing us to the knees, like the new pandemic has. The urology burden was increasing, and andrology, agony, anguish, all the challenges were bigger and bigger. We're looking forward to one of the modern patients who comes to you, and he complains to you 6 months to many years later that he has bent it like Beckham. Sadly, let's look into agony of one of them who has got problems of torque and curvature. 39 years in the prime of his life, can drive a Ferrari, but unfortunately cannot drive his organ into the female vagina. He has got progressive debility in the bed with satisfactory erections, but just incapable since the last few months, and now almost impossible. So his dilemmas are, which had normal and satisfactory erections, then progressively failing in the bed, making adjustments in his posture and attempting to continue doing that, and finally just cannot penetrate. He has got a gross dorsolateral cord. Just a case in isolation to show you. If the video plays, will be great. Some of the videos are embedded with sound which are presented at the World Congress recently. So this is just to look at the kind of Cordy when he has a partial erection when you're given a prostaglandin injection on the shaft. So when I look at him on a circumcoronal incision, sorry about that. So we're looking at, so most of these surgeries should be performed in rigid erection on the table. That's something which we may not been trained up. But back in Serbia, when I went for gender reassignment, I looked at all of them would perform these surgeries under continued erections, which means the erection is on the table. They would inject prostaglandin inside. And you have a man with erect with the Cordy and all those things. The measurements are very easy. Out here, we train differently, but there's a combination of the stuff that we do here in our country, and colleagues do practice in the audience a similar kind of technique. Just to enthuse few of our students around, we're looking at degloving the penis, which I do more frequently in gender reassignment. Out here, degloving has to be brought to that level of buccal fascia, where you have the blood supply to the penile skin maintained. That is what I use for vaginoplasty as a penile inversion of vaginoplasty. So I will look at the deepest layer to go in so that I actually don't miss out any blood supply on this skin flap. So we're doing that for this gentleman where we have to remake the whole organ, and we move forward step by step. Somebody in the audience yesterday requested me if we could show the neurovascular bundles. I've just looked at some videos showing the neurovascular bundle. But that is an important crux when you want to maintain the glans vascularity and the glans sensations in all kinds of reconstruction and andrology. I'll let him to move forward so that we can actually accommodate all, and Dr. Shambabu will tell me when to stop when it comes to the end. So you're looking at that. So even if we do a mistake of missing out that layer, we go back and then again come circumferentially and get that layer again. So that's the way we will go till we reach the pubic symphysis. Some of the key areas I've not edited deliberately for some youngsters to have a look at, but some of the key points actually matter. But otherwise, you're just degloving the penis right now. There's a long way to go. So we'll make the video shorter as we move forward. But those initial steps where somebody, one of the students opens up sometimes, we need to tell them which layer to be in, and that layer should not be missed out. So any layer which is being missed out will be go back, revisit, and come. Something like you look at the urethra and go back and find the small hole somewhere down, and we missed it out and we're moving in a false passage. Similarly, going back again and revisiting that layer again and again, so that we're opening it on the level of the buccal fascia. So that's it. So we have gone all the way down there. Gentleman has got dorsolateral Cordy. He may also have some secondary curvatures. Many times you forget. we may correct a good curvature, the primary curvature, secondary curvatures do matter. So you degloved him, and you'll do a closure back again just to show that. Let's move forward on the correction part. Sorry about that. Let's move forward on the correction part straight away that you saw this. So you're not talking about just a mild correction, but somebody who's just not able to penetrate in the last n number of months. The kind of both chordy and torque actually makes it impossible for him. So that is his possibly best erection that he gets. The better the erection, the worse he is on the bed kind of situation. It's all about corporoplasty, and we saw Dr. Tariq showing us some corporotomies. Very similar kind of work is done all over. So we do a corporotomy. Out here will be the challenge to identify a primary curvature and a secondary curvature, or identify two difficult curvatures in possibly a next small video. So those are the two main curvature areas. So opposite to that, you're going to lengthen that. So those are the curvatures that we see right now, but the main curvature is out there. I didn't use a goniometer till recently, but goniometer is a good way of looking at angles around. Could be slightly theoretical, but then that's it. Raising the neurovascular bundle. That's a little bit of time I want to spend on. Neurovascular bundles are raised right from the urethra on one side to the urethra on the opposite side. So we raise the entire neurovascular bundle because initially it was thought in 1970s, 80s and 90s that the neurovascular bundle was only at the top, but that's not true. They ramify all around from one side to the other side. And that's what teachers have actually worked and researchers have done that. So from one urethra on one side to the opposite side, you will go with a combination of sharp and deep dissection. You will look at going to the layer all the way there. And for friends who are going to do this kind of work and gender reassignment in this part of the country, we'll look at being completely on the surface of it. That's the knife moving. That's the easier way of not damaging the neurovascular bundle. And that's all I wanted to point. So once you're doing that, you can use a combination of scissors, and that's the time when you slow down your surgery. So you absolutely again on the layer, and finally you'll find the neurovascular bundle lifted from one side of the urethra to the opposite side completely. Yeah, so there are times I would do this in the non-plaque areas. And the non-plaque areas, easy to lift neurovascular bundle. At the level of the plaque, you may have injuries on the plaque. Better to have injuries on the plaque compared to that. That's what we use. We did, Ranjanda hosted a wonderful congress out here, and we had a chance to use bovine pericardium in Kolkata 2 years ago. We are going to use that bovine pericardium in this case and show you Gore-Tex in the next case. So you saw the erections, you want to go to the opposite side and lengthen that side. Sometimes a mistake for the cameras, we should not be doing it wrongly. Somebody in the audience, somebody in the table will keep reminding you, you're lengthening the side. So opposite side, you're lengthening. You're looking at the curvatures and found that the primary curvature, that is the crux of the whole matter. You may get a little J and S-shaped penis also in due course of time for very neglected cases around. But that was, I was looking at the secondary curvatures, which I am correct by Nesbitt. So I went to the opposite side and I would do a corporotomy, as rightly said by Dr. Tariq. We'll go all the way thick into tunica albuginea, but not get into the real corporal tissues. I make it H shape. I make it real H so that it gets those fangs which go across, and therefore you don't have a torque created by your surgery. Many times after you're done, there's a torque which is created if you have been less. So that's available. That's made in Chennai. And that's a company which actually supplies that. Many of our other department colleagues would be using it, but for urologists, now it comes in andrology, where you're picking up. It's available in various sizes, comes from the cost of anything between 20,000 to 40,000, depending on the size. The size that we in urology need would cost 22,000 rupees. I would not do that technique anymore, but that's an older video where I actually keep it there and start suturing and cut later on. Out here, I've already cut, but I would take those 4-point sutures at the edge margins, and Dr. Rupin does a slightly different technique. He was the one who baptized me into this. I was only doing Gore-Tex till I started doing this 4 years ago. We must have completed more than 40 cases by now on this, but I still use Gore-Tex at times. Regarding the tourniquet, I just heard the pediatric colleagues talking about no tourniquet. Tourniquet here is on and off. We use it for not more than 15-20 minutes. You've seen that the corporoplasty is getting over, but you have got those secondary curvatures not corrected yet. And that's what you could correct by smaller kind of, much smaller Nesbits. So that's you're looking at those, looking at correcting those by small Nesbits. So again, please measure yourself and look at your best erection and look at correcting those smaller one with Nesbit. So do the small Nesbits there. Sometimes we need to do a glance tuck also because the glance may be floppy, and that's something done ventrally. Again, the sutures that I use, and I think we've started using is PDS. Before it was all Prolene, carrying it to the grave, but no more so. We all use PDS right now. I mean, you all do various techniques and all techniques are good enough. Finally, these are all being done under the neurovascular bundle. And therefore, neurovascular bundle covers it. That's extremely important. Never leave the last part of the surgery to your lesser experienced colleagues in the beginning. They need to apprentice to those levels around because the last part of the surgery matter a lot. Which means the neurovascular bundle cover, the skin cover, and the dressing part, please. That's the only part which sometimes we have. So that's a little glance stuck. We probably bring the glance, floppy glance straight there because men want everything longer and straight. None of us in the audience will have everything straight. But when they do a surgery, they want a guarantee of 102%. Getting difficult in andrology because, they can see everything right from circumcision around. So you got to look at everything that you're promised or not promised. Anyway, you're having the best erection on the table. I would actually enthuse people to use prostaglandin injection and keep this erection on all the time. I don't get that happening, but that will be great. And repose back. Showing this last part only to look at the dressing part. I use Coban dressing, which is available in India. And I keep the dressing on for 48 hours in everybody. When I do a penile process also, I keep a dressing for 48 hours. Lest somebody at my age may get a wonderful erection, some hematomas and things may go wrong. So that's a Coban dressing, a dressing which can breathe. The penis can breathe to it, but will not be able to bleed through it. So that's what I leave for 48 hours. It's a dressing through which the penis can breathe if it has to, but doesn't get that erection which tears the sutures, etc., etc. I leave the catheter for 3 days, and thereafter the patient goes to his town, and my colleague friends in various cities take care from there onwards. We quickly move onward to the next one. Sorry.
Sanjay.
Sir.
Actually, we have used this bovine graft for urethroplasty, and very few, at least more than 20 to 30 cases in our department actually, when I was at National Medical College. But I don't know, the boys has shown yesterday, the ultimately graft actually fails. We had to convert again. So I don't know whether how much it is working.
I'll tell you that. Bovine pericardium, Rupin Shah has follow-up for 5 years. I only see for 3.5 years. Patients are doing well. I'm just going to next one. I'll tell you why did I switch around. So let me just tell you that, sir. Quickly show you this part. All penile surgeries are best done if you can handle the penis by the glans. I trained in that technique and always handle that with a stay suture, which is 3-0. We will quickly move on this. I don't want to show degloving anymore, but I like to look at this patient somewhere here, the neurovascular bundle lifting around. So once you lift the neurovascular bundle right from the urethra on one side to the opposite side. Dilip, I heard your comment. I'll come to that comment. I'm just trying to finish off. Shyam has given me a time.
One thing, is cardiovascular surgeons are regularly using it. Probably it is the blood which is not producing any problem to this graft. But urine may produce problem to this bovine graft.
So urine should not come in touch with it.
Urine should not
come in touch with it. Yes. Very much. Something like the process. I'll show the processes. I'll talk to you. So we look at the neurovascular bundle. Out here, there's difficulty in lifting at the level of the plaque. The plaque, it may not look so easy sometimes. You have to injure the plaque actually to lift the neurovascular bundle properly. That's it. And then you go all the way down. Just that part of the surgery here, and then we quickly move on. Out here, I've used Gore-Tex. I want to just come back from Gore-Tex. I work in a multi-specialty hospital. I'm a little blessed because I get Gore-Tex free. Our cardiac guys use a lot of Gore-Tex for their issues around. So what I showed you was bovine pericardium, but now quickly when we shift over to Gore-Tex, have a look at, looks very good. First few months to first few years have been good. But I gather now, I did ask the world authorities and they said there's a fibrosis in that, which is not seen in bovine pericardium for the 5 years that Rupin Shah says. I've only had 3.5 years follow-up. We'll be able to answer you in Rajgir. So here you are. So once you lifted it around, there's that hard plaque which I'm almost grating on. That's the one. So we will move on now. We will quickly move on to this. Again, you can see my marker is jumping over the graft, over the plaque. The plaque actually has been injured out there. Out here, the curvature is, the whole plaque and the penile surface is so hard. It's very, very hard. And my choice only here is to do one thing, is to make 2 incisions rather than 1. You will look at this here. This is something where I made 2 incisions because 1 incision would not have worked. Once I made an incision, the penis lengthens up because that's a technique where you expose the corpora body, but you give the tunica albuginea that kind of a choice. So that is 1. But you can see I'm hiding another one. So basically, this is something which, those people try the most technique. That's Gore-Tex, comes in various 2, 4, 8 millimeters. This is the one which can be actually sterilized 3 times, as the company says. It has been used by cardiac guys sterilizing 3 times. So you can still re-sterilize these. Open up the Gore-Tex, and Gore-Tex is versatile, very wonderful, good feeling. Doing is fun. So a patient from Bangladesh, after 4 years, reported a lot of hardness in that area. It was soft. That's where I gathered that we're dealing something. We called our 14 patients around and checked. And they may not have felt it because they were still capable performing, but the area was hard, which we had not left. So you'll find me again and again getting back to tourniquet, removing the tourniquet. So we did the whole incision without the tourniquet. And then we're looking at some degree of oozing and bleeding. And we go ahead again with the 4-point technique on the edge incisions. And we close it. So nothing specific again. It is all about going into the right layers, incising and grafting. There's no excision and grafting like the Derovid's operation, because sometimes you may land up excising a very major amount of circumference. You need those tissues to suture up around.
Sanjay?
So go ahead.
Yes. Anytime you have used saphenous graft?
So I've used saphenous graft when I was in Chennai. I've used it. So the saphenous graft patients, we did not follow for a longer period of time in that era when I used it around. I've used saphenous, I've used Sudhakar Krishnamurthy's technique of dermal graft around. But the follow-up, which Dr. Rupin Shah did talk about on these cases around, on which I started my techniques 14 years ago in Chennai. I'm not sure about your follow-ups on that. That's the only issue.
Follow-up is all right. But only few cases, 3, 4 cases.
So I haven't used saphenous in the recent times.
Have you used the buccal mucosal?
Yes, so buccal mucosal graft, the West says fibroses a lot in this technique. So please don't use buccal mucosa at least. Saphenous has been the standard of care in the past. Here it was to show you that we had 2 grafts instead of 1. You can see that. And please keep it as watertight as possible and then bring back. And so that's one. So these patients maintain great erections.
Using the external, this aponeurosis, this sheath.
The fascia lata. The fascia lata. No, I haven't used that.
Taking a part of the rectus sheath and put it there.
Possibly I can, but I'm not sure whether I can actually.
It was used to repair the hernia.
Yes, so fascia lata and all have been used around. That's one good way of looking back and probably comparing 2 grafts and moving forward. I move forward on this because we have done with this around, and let's move forward on something which is the new. I did not bring the 3-piece, so I'm showing the 2-piece right now. The one which has been introduced by the Boston Scientific, the AMS. So this is the one we did very recently. We did a workshop here, and there were 3 cases on that day. All the 3 required different sizes around. So that's the new one, which is available in India at still a premium cost of 1.5 lakhs compared to 24,000 by Dr. Shah. But this was the one just to show you the kind of technique which we use, little different technique compared to what we use. Both the processes which I show you are on cases of, this is robotic radical prostatectomy, post-robotic radical prostatectomy. Believe me, there's an ischemia in the corporal bodies which happens post-radical prostatectomy. This was highlighted in this case where we are finding it very difficult. And the first one was actually a redo case where there was a penile fracture. So out here, it's all about, again, getting it. So you find just a little different from what we are going to show you in the first one. Out here, the AMS one, where a standard technique using the ring retractor so that it becomes absolutely no touch. None of the assistants hold anything around. You make 2 corporotomies on both sides. Go ahead, dilate with Hegas and place it around. Those tips and tricks are known to us. We got to prevent a urethral injury, else we have to abandon it. Or we probably prevent an injury to the opposite corpora. And that's where those times when you slow down the surgery, when you dilate. So if you know the history of a patient who has got a radical robotic prostatectomy, please believe me, they have ischemia and the corporal. We've done around 6 cases now. We wake up and probably look at using a cavornotome now. In the era, I was using scissors But now I would use a cavernotome because they have got an ischemia which fibroses the corporal bodies. It's not that just the nerves were cut, but there is an ischemia which develops. I would always look at having so this is one of them where I had to use scissors to open up. The corporal bodies were firm to hard. He had no previous surgeries. He had undergone 51 years old in Delhi, underwent robotic radical prostatectomy, and thereafter was struggling with his erections for 3 years and then came in. And I was in the right plane, but I was not able to find planes. The corporal bodies were such. You'll find me using scissors, something that you will not find very regularly being used. And then somehow we could find a smaller dilators starting from 6, 7, keeping the tips of dilators to the lateral side all the time as the teaching goes, and then you could proceed. That's a no-touch technique, as assistants and all don't come into the picture of holding frequently. So you use a ring retractor to your benefit. Subsequently, what happens is when you dilate the first few, gets easy. Thereafter, the larger dilators which need to go in gets a little difficult only because then you start shooting below the tip and you need to continue checking that with your glands fingers out there. I always use a catheter. Sir says not to use a catheter, just catheterize and empty, but I always use a catheter. It helps me to identify few things on the table that we've done our mistakes in our learning days. And then continue dilating it out. I will not stick long here. We'll quickly move on and continue dilating. And once we have dilated them, it's all about measurements. Let me come to the opposite side, corpora. We do a corporotopy on the opposite side. Again, that side was equally tough. And we used the scissors initially, and we got through the right plane, opened up with scissors, prefer not doing that in the normal cases, and then after the dilators started going in. Just to keep some of the unedited videos a little shorter. Again, as you're dilating, the tip of your Hager's dilator is pointing laterally and not medially, and you're keeping the penis, though it is kept under stretch already. During the entire surgery, you're still holding the tip only for the reason of continuing that safety. So once you have gotten both sides, you would, sorry again. And that's where you will look at the goalpost and see that you've dilated both till the level of the pubic symphysis. Now you've gone to the right dilatation on proximally, then you've dilated distally. There are ways of measuring. We still use a very crude way of measurement, and we're happy with the measurements in the last 95 cases. But there are techniques to measure all this on the table to be absolutely accurate. The accuracy will have to come on table with practice. And we're doing the last part of the measurement there, and then we move forward. This is important part of it that we will have to look at. Instilling infusion and looking at you don't have a urethral injury, very, very important. So infuse and check you don't have urethral injury. I just did that. I want to move the video faster. And then it's all about measurement and placing the process. So just to give you an idea of this new processes, it's firm and very good, more natural than the Shah's processes in terms of rigidity. Shah has gotten wonderful variation from softer to harder ones. Dr. Rupin did inform me that he has got the OS one. And the OS is what I use in transgenders, otherwise it would migrate out. And what we have here is, so let's move forward on the implant part right now and get the implant. And again, the measured implants are cut. So these are the new implants that you have in India right now. They cost you 1.5 lakhs. They come in 3 sizes. Recommend that whenever we do these kind of workshops or even single case, all the 3 sizes should be there in your operating room because you don't know which size would fit him. Even if you have done the stretch penile length, you looked at all that. Out here, the Indian processes scores very high because you have got Rupin Shah actually getting us those strips which you can strip off, and therefore you can make them asymmetrical. Not very easy in this, you have to shave. But if you shave, the inner part of the hinge will be destroyed. So after you have the rear tip extender, you already measured it. So it's all about applying and placing it inside. Let's get into the placement part. Has got a very natural feel and a good rigid feel actually. I want to show you the Indian processes which actually will give you an idea about. So instilling fluid on both sides and looking at does not come through the urethra proximally, distally, sorry. And if that happens, that means you've perforated your urethra. and both sides. It's more of an antibiotic solution. I use amikacin, metrogel. So that's the infusion distally to look at that, nothing. And then there always will be a technique every surgeon will employ, looking at which side to place first. ये क्या हो रहा? ये कैसे हो जा रहा? कुछ कर रहे हो आप लोग? कुछ कर रहे हो आप लोग? अच्छा, यहीं से खेलने दो. And then we apply the other side, and then if there was a plaque here, then there would something called as molding on the table. So if you're doing it for a plaque where you're not doing too much of work, you do a molding on the table for those smaller plaques. I keep the catheter for 24 hours and a dressing along with it for 24 hours. We'll quickly move to the Indian processes. There is something to show there. So this is, otherwise this will add on to. Go ahead. So the plaque actually can be broken. That's a technique now which is standard of care for smaller plaques and hard plaques, where you are not doing too much of plaque surgery, where erectile dysfunction is the main problem and not his curvature. That's where they put two processes and they mold the plaque and break the plaque inside, and they put a dressing Coban for 96 hours. So that's the way the plaque is broken. There will be a set of fibrosis set in, but the processes are taking care of everything. So the whatever manual hematoma will form, the processes will mold it, and the penis will look straight. The plaque will not be. Otherwise, plaque will stand out as you put the prosthesis in cases we have not done an incision and grafting. So that's the end of the story. Put a subcuticular sutures around and come out of it. So that's molding of the plaque. And so that should be it for this one. We quickly move to the Indian processes, and that is versatile to me all the time. Now, this patient was a post-urethroplasty status, undergone a redo urethroplasty after having posterior urethroplasty. And we had done a redo urethroplasty 3 years ago. We made him wait and think waiting would help, but he had tried everything on earth and probably nothing was working for him. So we quickly moved to the area where I have to use scissors out here. So this was completely fibrosed kind of thing. That's not standard technique, but that's a technique in those. Use a cavernotome is a better one rather than using this. But if you use dilators, you may perforate and go out of it. So finding the right place, having more of stay sutures, and then finding the right, and then probably. So I've used scissors everywhere. These are those difficult cases: fracture penis, ischemia, surgeries done, extravasations done. That's where Dilip, your argument on anything which is now going to be foreign outside this. Therefore, don't do a combination of graft along with a prosthesis. You may possibly be sometimes in trouble. We do it. And if anything happens to urethra, abandon is always a choice. So again, here the same technique, but I would like to show you the prosthesis which can be stripped. So maybe I can move forward on this quickly. So again, instill and check that all water comes out from here only and doesn't come by the side of urethra. That's Shah's processes, the versatile Indian processes. It has got those layers which you can strip. Remember that. So that's antibiotic solution. It's kept there. It has got they are hinge and non-hinge kind, and there's a whole set of things we can discuss someday. And these are both hinged for a longer penis. The hinge serves better, and the hinge actually gets placed there. So once you have got everything done, you want to do your tests to be sure that you've dilated properly both sides independently and then together, and then you measure. Measurements matter a lot. You can also alter it on the operation table after you have measured and then divided. Back in the Kolkata workshop, and we were struggling in the evening, I remember we actually did tailor the tip. That's what I've shown here too, because the tip was not allowing us. There was distal fibrosis, and Dr. Devmalya and Dr. Atanu and I were both, three of us were struggling that day at the Apollos, and not able to get the tip late in the night. Yeah, so his ideas came. So Dr. Anjan actually from the audience told us, why don't you tailor the tip? And Anjan, I actually went back to Bombay and did one case where I tailored the tip. This is one of them. Ischemic penis in a young man. Ischemic because of reasons of iatrogenic or ischemia because of trauma. So we looked at the dilatations have happened well. We looked at the size, and then you look at either 11 or 13 as it allows. This is where you can be asymmetrical. You can't do it any other case. You can't do with any of the processes in the world other than the Shah's process. You can be asymmetrical. You can have different sizes placed because you can strip off one of the strips out there. So it comes with multiple layers. So imagine if this accommodates, then you do that important test and look at if there's any gap inside. If there's any gap around, then you will make it wobbly. So after having done and checked that both of them are at the tip, we look at the gap between both of them. We hold it and look at the gap test. If there's no gap, we are happy about that we have got nothing left in between. If there's a gap, we will have trouble. So that these are all small tricks which possibly will always come with practice. So there's no gap here. Both of them are level 11 size and it goes well.
Sir.
Yes.
Post-priapism case.
Samir, this one.
Yeah. No.
Yeah, I've done this post-priapism early.
Yeah.
But when we have done late, we have been in trouble. I have bought a cavernotum now because you have to go through it. You have to absolutely excise rather than only incise and get out the copper tissue, which are very fibrous. That's the thing I'm talking about. Stripping off wanted to show that you can strip. Stripping is not easy. We actually have injured a time or two the processes. So you have to strip it off and you can strip one layer and make it thinner. So you can have two asymmetrical sizes placed 11 and 13 kind of thing around. If you strip this 2 millimeters out of it, it's made wonderfully. It's made in Agra and all credit to the Indian mentor. So that's how it is. Now, if I would not go, I could actually do something at the distal part. That's what I may have shown here. So these are important aspects. You've got the rear tip extenders, you've got stuff. Out here on the opposite side, we're making a little bit of adjustments so that because our opposite side dilator was going very difficult when it was 11. We wanted to still place 11 because the gap test was negative. Something which, Dr. Sonajit, we hail Anjanda for that technique around. I said we should do this. And it worked very well for us. So this is only going to happen in Indian processes. Very versatile, still come at 25,000. And then you can incise, you can place the right size, you can put the rear tip extenders, zero extenders, and proceed further around. And then again, you always come and redilate again. Remember, these are all man-made holes that you have created around. Redilate, recheck, instill infusions. Keep it as no-touch technique. Keep the process as short as possible rather than prolonging long. Minimal amount of traffic into the operation theaters. Though all the workshops and all kind of OTs, people want to come and see who is the patient demanding this. And many a times, doctor patients are done at 6 o'clock in the morning because they don't want to reveal the identity. Most of the doctors want to get it done very early in the morning. You can see the tip there, which I had actually excised a part of it. Sometimes, and then also it was difficult to go. So we had to really place it around. He is a happy man. He's a happy man now. This is 11 months since his surgery. And he's a happy man that he can pee well and he can perform well. So I'll just take a break from here, quickly go to the next part of some other presentations, which I found quite difficult to get in till I actually got it. And that's where I got in around and he has got something. So this does not stand with me very well when I do gender reassignment surgery. That's where I cannot have this kind of rigidity created around. So that's all. And then you close the tissue around and you can look at, you can conceal it very well. And that's where the hinge processes of Dr. Rupin Shah allows to conceal it completely well. It actually works in our favor. So I just go out of this video and go to the next one. Dr. Shah had requested me to show quickly on few things around. When we do a male to female, I want to show you a very short video presented in the World Congress virtually last year. We have gone to, many of us don't do microvascular surgeries around. I've had some failures in microvascular when I trained in Serbia, and I've gone to more of these pedicled ones. This is one of the pedicled ones. If the sound plays, I move forward directly with this. It's a very short video.
Stage skip flap phalloplasty could be a standard of care in gender reassignment surgery, is what is being demonstrated at the Kokilabin Dhirubhai Ambani Hospital's technique. Gender reaffirmation phalloplasty
So that's a skip flap, which is on a perforator.
To create a successful neophallus.
If you see this patient, he is not a transgender. He's a man with micropenis. You'll see the scrotum coming into picture again and again.
Sensate, hairless, and similar in color to the surrounding skin. Here, we demonstrate a technique
that's
of
a stage technique.
phalloplasty in the evolution of the technique that we have taken forward.
So plastic surgeons used to use it for burns and all in that era. From thereafter, it was used by a urologist to do in the Western world,
to the level
and then was given up.
And with the aims of creating a phalloplasty which will be both functional and aesthetic, we're looking at a 14 to 15 centimeter of the neophallus with minimal to no donor site mobility. The phallus is capable of accepting a pedicle flap urethroplasty by contralateral skip flap, or by a stage urethroplasty at a later date. At this point in time, we are looking at very close vascularity check of this flap by being able to take this flap, harvesting it under the circumflex iliac artery perforator.
So it's based on a
And
perforator.
the pedicle of
That's
that
the
will be
technique.
rotated
That's the
to
crux of the
bring it
technique.
to the center.
That's the perforator.
That attempt under a microscope or with a loop is to look at being isolating the vessel so as to look at the crucial step of the procedure is identified and the procedure is slowed down. A very important aspect of skip flap is to maintain the vascularity of that important pedicle. While we took up this entire procedure
So he's a
in the
micropenis.
early days,
He's
in
not a
cases
transgender.
of micropenis, and we looked at bringing it down to our cases of gender reassignment surgery, the creation of the space at the level of the pubic symphysis is shown in such a case.
Then you tunnel the flap.
So this case is a very case that we have taken up over the last 32 cases, where we have brought about a skip flap that has been then tunneled underneath to bring it to the center of the entire situation.
Over the last
While
3 cases we started doing,
you
and now
find that
anastomosis,
this
which was
pedicle
not
flap,
happening
which
in the
is
first 30
full
cases.
of fat, will later on be defatted, is gradually rotated and brought to the center. This incision at the center was at the level of the pubic symphysis, and that was then later on loosened out. So you can see the dermal excision of the extra amount of skin, which would be required to bring about the removal of the skin, and then removal of excessive amount of fat, which would not let it fall. When the flap is completely raised and the closure started, the pedicle is then looked at. It should have no stretch. A continuous look is always maintained on the blood supply of the flap as the flap is kept stretched, and the closure is done with interrupted sutures. At this point in time, the donor site will be closed with adequate mobilization with a semi-flex hip towards adequate healing. The skip flap phalloplasty is an attempt towards a 3-stage procedure where the first flap is a scaffold created as a phallus, and this phallus then holds the ventral urethroplasty, which is a tunnel urethroplasty, from the region of the labial flap urethroplasty, and the vaginectomy, which is done at the same stage as the second stage. So as you see that this ventral suture line is being created, small spaces are left in between towards any oozing or lymph drainage. The donor site can be adequately mobilized with the flexion of the hip at this point in time to create any tension on the suture lines while the primary flap is being closed. We have later on brought about inversion of the tip, anything between 0.5 centimeters to 1.5 centimeters, to be able to match the urethroplasty requirements, which are important here. These patients who in our situation were from the age group of 21 to 39, where 2 cases in our series had complete and immediate graft loss due to vascular compromise. 2 patients had to be divided towards distal shaft amputation of anything between 1 to 3 centimeters. The vascularity was hampered. Only we went back later to identify that these patients were smokers. That shaft is then nursed in a vertical position to maintain it around. In 6 patients, the urethroplasty which was done could be actually maintained around. So why skip flap when there are other options too? The radial forearm free flap phalloplasty, anterolateral thigh flap, and abdominal flap had actually got established. The skip flap is one which brings about minimal dolus site morbidity and concealment. A major cutaneous vein drains everything. Deeper and longer dissections can be taken around. To conclude, though the free radial forearm flap, though established itself for time, has major problems like donor site morbidity and kind of scars which are left around, the road to skip flap has not been very smooth. In the early days, we had our own lumpy, bumpy starts, but at this point in time, we've reached a point where in the last 32 cases, we evolved to create a double skip flap to be able to take this.
So out here, I gather that our first 30 cases, we did not have any sensation at the tip. And I was using Dr. Shah's original processes, and we had 3 extrusions around. That's where I learned that he has another process which is called as OS. The tip is soft. That's probably for these people he had made. So that actually worked. So if I show you a penile prosthesis in a very short video, have a look at this.
Stage phalloplasty towards aesthetic and functional neophallus entails creation of the organ that has satisfactory penetrative capability in completing the
So
journey
this
of
patient actually had
continuing
undergone a radial
milestones
forearm
for the
flap
individual with gender
and it had failed.
dysphoria
Then we
in a
did a skip
female to
flap.
male transition. In
So that's a skip
reconstructive
flap
journey,
result.
placement of a penile
You
processes
can see
in a
the radial forearm
neophallus
flap with
gives
the
a
thigh
much needed
scars are all
rigidity
failed.
towards capability
And you
of
can
the
see
solve.
that
Today, we
skip
demonstrate
flap
a
scar
technique
there,
of
the
placing
scar
a
on the left
semi-rigid
side.
processes in a pedicle flap
That's a
phalloplasty
post-skip.
and the evolution of our technique in the series of 27 cases done so far. This is a patient of failed radial forearm flap who underwent a staged skip flap phalloplasty at our institute in the Kokilabhen Dhirubhai Ambani Hospital.
So that's
You
where
could
the
see
urethra
the
goes.
midline scar
The urethra
of
goes
the skip
ventrally
flap
and
phalloplasty in the midline.
processes goes dorsally.
The very aims
the
of
glands.
presenting the innovation of placing this semi-rigid prosthesis, which is called as the Indian
When I invert the
prosthesis,
skin, I get a little
devised
bit
and
of
innovated
urethra of
by
the glandular urethra
Dr. Rupin
created.
Sharp, the doyen of Indian andrology, as a successful and a strategic model, is then strategically implanted on the dorsal aspect of the neophallus, thus leaving the ventral aspect of this phallus towards pedicle urethroplasty at a later date, anchoring the processes to the pubic symphysis and thus preventing migration, creating the very specific rigidity and the penopubic angle, and assessing the evolution of the current technique towards assessing our explantation, extrusion rates, and
We
acceptability
always
of
do a
this
Doppler
innovation
before we
by our
incise
patients
there
is being looked at.
because the main pedicle is somewhere
While
close
the
by.
patient undergoes a Doppler ultrasound of the penile shaft, which has matured itself, this patient undergoes an incision on the base of the shaft on one side, and we take this implantation as a single malleable processes, which is taken up all the way into the tip of the shaft, leaving that 1 inch of the future glands to be left soft. The incision is deepened all the way to the level of the periosteum of the pubic symphysis, and as we take it to that level around, we attempt to look at strategically able to dilate a new tract being created on the dorsal aspect of the shaft. The shaft is stabilized at the base later on. So while we do this intricate dilatation of
There's no corpora
the
here.
phallus, we continue to balance it and look at the dilatation continues to be on the dorsal aspect of the shaft,
So always
while the
dorsal.
ventral aspect is left behind. This dorsal aspect dilatation by a graduated Hagar's dilators up to the level of 11 or 13 requires an antibiotic cover and a continued antibiotic irrigation as we dilate it to the required length, which we would cover with a much needed circumferential activity by the Indian processes. The Indian processes is amazing in terms of being able to be tailored to the need of the circumference of the shaft by being able to strip layer by layer as required to give it the actual girth, which would give it the much needed rigidity without being too thick or too thin. It is available as 2 pieces of malleable prosthesis with
So
a
we
hinge
use only
in this
one.
case as
We don't
being
have space
visible to
for
you,
two.
which is implanted in normal males. But out here we have the luxury of these 2 or 1 to be used in a sterile technique under antibiotic solution. As we pick up this and identify it to the size of the predetermined dilatation that we have done, switch it between various antibiotic solutions, we reach and understand that the size that would fit this very important case of the neophallus thus devised. The exact measurement of the circumference and exact measurement of the length is very carefully assessed to fall short by few millimeters rather than keeping it longer. And that's one innovation that we have learned over time. Overstay sutures, as we gradually modulate this into the new tract that we have created, we look forward to placing it correctly in the location that has been devised for it. This placement, once completely reached to the tip, which is approximately at the level of the glans, penis and the coronal sulcus, as we have marked in the early part of our surgery, we identify the actual measurements that could then help us
You can
see
see
its
the struggle
location
because there's
on
no
the
corporal
periosteum
body.
of the pubic
Created a
symphysis.
track, it disappears every
In
time
our
you dilate.
series of stage phalloplasty, 27 patients with pedicle rotation flap done anything between 3 months ago to up to 4
check on the
years
blood supply
on
many a
their
times.
request have undergone this penile processes as a single semi-rigid implantation, which has actually been stabilized very well on the periosteum. In the early days by proline sutures, directly sutured to the full thickness.
This was an early
of
technique which you have
the
abandoned
implant.
completely now.
Having done so, we then incise and are able to bury the rest of it onto one side of the incision. The incision is then closed. We looked at our entire series and understood that in the early days, 3 patients with this prosthesis had explanted due to migration and tip necrosis. And the migration could have happened because of the suturing techniques in the early days, which approximately started a decade ago. One patient actually was lost to this prosthesis because of an infection and persistent drainage, which was in the era when we started using the Prolian mesh as an anchor at the base for the prosthesis to be fixed up there. One patient did not use the shaft of this kind of a penetrable rigidity, but only wanted it for upright wording. But the rest 22 patients have been stable enough with satisfactory capable results in the bed and capable results in shooting their stream onto the location that they have always dreamt in and thought of. In the later series of 15 cases, we have been able to anchor the prosthesis to the periosteum with minimal anchorage needed by the collar of Prolian mesh that we have used. I stop that there and just go to quickly 2 short cases. So we have stopped doing Prolian mesh also. It was getting infected. Now we use only Gore-Tex. And Gore-Tex is one which holds and binds it. I don't get extrusion of these processes anymore. They're anchored to the periosteum very well. Quick 2 short cases for understanding that why are we going to handhold our gynecology and our girls in this future around is like this. Intermittent abdominal pain at that age of 12 years. She had lower abdominal pain for 5 months and not even parents recognized, not even pediatricians. But what she had was a hematometra. That means she was born with congenital vaginal atresia. Sit down in Google right now, you'll find that the incidence of congenital vaginal atresia is 1 in 20 to 1 in 40,000 live births. That means girls are born without vagina. God forgot to distribute vaginas so frequently, 1 in 20 to 40,000 live births. There was just one case to start with in 2011. 10 years after surgery, she still follows up. I want to tell you what was her technique, and this was her technique. Very short 2-minute video just to show you. At that time, I was doing open. My other disclosure is I never learned laparoscopy. So I had to convert myself from laparoscopy to robotic when minimally invasive era came in. That's an open job. We used to use sigmoid in most of the cases, but out here the sigmoid was very, very small. There was no choice. I could have brought sigmoid down. We looked at an ileal segment. So she is one rare ileal vagina compared to all sigmoid vaginas. A very short one to show you that, again, as you use for augmentation cystoplasty, you look at the pedicle where at least 2 vessels can go in. The bowel is prepared, not so well prepared, probably by our new residents. But then we look at that 15 centimeter adult vagina which you create, and that adult vagina is then brought down, the end with a longer kind of a pedicle. Out here don't have marginal vessels like sigmoid. So ileum is not a very favorable thing for multiple reasons around. So we bring it down, we take it over the mold. That's what I want to show you. That's over the mold. Because she has got vaginal atresia, upper end will be anastomosed to the cervix or to the effaced cervix, the uterus. Lower end will go to the introitus. She was a patient who has been followed up by colposcopy for 3 months for the first year, like the malignancy bladder issues, and then 6 monthly for the second year. Her mother used to calibrate and dilate. Now she is 21 years old, 10 years after her surgery. She still follows up and comes and says hello, and possibly has become an ambassador for this subject for me. But I go to another one, and that's where I want to talk to you, is that there is androgen insensitivity syndrome, again, no less than the same kind of incidence. These patients are reared as females, and she's past 46XY. When she was sitting across the table, she said, Dr. Pandey, I want to continue to be a female only. And that was her crux of the matter. So her bilateral testes were removed, and she underwent a robotic sigmoid vaginoplasty. She lives her dream. It is now 5 years, 4.5, 5 years. She goes and tells her story. But the next case is the case of MRKH syndrome, another kind of an issue which, as urologists, we will be called upon, because what we get to see right now are the years of our gynecologists doing skin grafts and skin flaps. The skin grafts have not stood test of time for these young girls to be sexually active in the future. MRKH syndrome is a completely different story, showing to you one technique which me, Bijoy, and Ismail took over quickly to give you an idea on this case. Sigmoid vaginoplasty has established a unique place in reconstructive gynecology. That could be my last video. Robotic assisted maybe one more short video of a few minutes. Finally can be an innovation that changes life. Is demonstrated in a 22 years young girl who presents with vaginal atresia, absence of uterus, and thus a Mayer-Rokitansky-Kuster-Hauser syndrome. She presented to our hospital as a 22 years young girl who was referred with primary amenorrhea. She was thoroughly evaluated and an MRI done revealed an absence of vagina and uterus, but bilateral normal looking ovaries. She had normal secondary sexual characters. Following that, a cytogenetic analysis was done that revealed a 46XX chromosome karyotype.
thereby demonstrating a male occupancy Custer-Hauser syndrome's diagnosis. She had a normal female karyotype. The MRI had shown atretic vagina and absence of uterus, and she had bilateral normal ovaries. Robotic assisted sigmoid vaginoplasty docking and port placement was very similar to a picture of deep pelvic surgery, which we do in robotic XI instrument.
Taking to robotic only for the
Position were given
cosmetic
such
reasons
that
here
we could have free
just
access to
helped us
perineal
innovate.
dissection down there and could reach all the way down.
So you, in XI, you can do both together.
Identification
The
of
perineal job.
the balloon of the catheter in the bladder. The pelvic segment shows that there's absence of all Mullerian structures. Rectum was identified by insertion of a pack and my finger segment out there. Scoring was done on the peritoneum to denote the location of the neovagina, which actually is a thin wafer line at this point in time because of the absence of that entire segment. We can see that there's absence of all Mullerian elements, that there's no vagina and no uterus in this female when we see the perineum. At this point, we assess the mesenteric mobility to attain a tension-free anastomosis of a planned sigmoid segment. This patient has a lavish, very free and a redundant sigmoid, which is a good news.
We're lucky to get two
choosing
pedicles
of
out
this
here.
sigmoid segment. Once we establish the mobility of the sigmoid segment, we look at the length that we need to identify, and that identification towards creation of neovagina is with demarcation of proper blood supply. At this point of time, we find there are two good pulsating blood vessels which could supply this approximate 14 to 15 centimeters of neovagina that will be placed deep in the pelvis with a proper access. Once the segment of the sigmoid is identified, we use a pre-marked thread which is inserted to accurately measure the site of the sigmoid that we would be incising on both the proximal and the distal sides. That measurement is carried out over stay sutures at the distal end initially and then our proximal end. So the stay sutures help us establish a proper segment with the blood supply that we have looked at when we started the surgery. Once the stay sutures are placed to measure the distal and the proximal ends, the incision is to be planned, and for which we would mobilize the entire segment of the colon of the lateral pelvic wall, that is the psoas muscle. This liberal sigmoid mobilization all the way to the proximal segment allows us to plan a proper incision and movement of this segment. So that mobilized segment with complete mobility assessed and planned is then taken for division, and the staple is introduced from the assistant port. As we divide the sigmoid segment by tugging it and bringing it completely into the stapler, we look forward to the colocolic anastomosis, which is a side-to-side anastomosis.
It's an end-to-end, but done side-to-side with the staplers and then the third stapler.
Segments are brought in, rolled over side-to-side within the stapler, and the staple is fired.
In this age group, robotic just stands
complete
tall as much as
colocolic
laparoscopy,
anastomosis is
only
thus
for the
established.
cosmetic aspect of a large incision. Otherwise, we
The
still love
extra and the
doing
redundant
open
segments are excised. And at this point in time, our sigmoid segment with a good vascularity is waiting in the pelvis. We at this point in time would go back to our pre-scored area between the bladder in front and the rectum behind.
That's where the
The
XI
perineal
robot
surgeon
scores
helping us
better than SI.
with his
In
finger
XI,
all
you
the
can
time.
do both together.
So dissection is started at this site of the pre-scored segment. To be very careful that there's no organ in between.
There's a wafer line between rectum and this one. And that's where a perineal surgeon is sitting in the
digital
XI and is able to
examination
put his-
helping us all the time towards any injury that could happen to the rectum.
These kind of surgery,
The finger is
consent
inserted to
creation
the
is an
prospective
issue.
site of the introitus, and the site of neovagina is dissected gradually. Finally, the fingers from the perineum are brought in. We lose a bit of pneumoperitoneum. The detumularized segment is then gently pulled out with the Babcocks into the perineum. At this point in time, we are assessing this segment which has now been mobilized for any extra tension that could be placed onto the neovagina. So very careful dissection of the mesentery is carried on to relieve any tension that could be happening in the neovagina as it is lying in the proper axis. As you place the neovagina in the proper axis,
with the upper end closed and the lower end deep in the perineum now, being managed with the perineal surgeon who would anastomose this to the introitus. The vascularity is looked at and checked doubly. The mesentery is looked at, keeping free.
Just wanted to show you the colposcopy.
And the pelvic component
in this case, and the girl 10 years later
is
That's
covered
part of end of the video on there.
by sutures so as to bring about a closure of the pelvis. At this point in time, the abdominal drain is kept through the left 8 millimeter port, while the perineal surgeon brings about interrupted anastomosis of the segment to the exterior, bringing about a new introitus. The XI is subsequently undocked and the surgery is completed. Post-operatively,
So that's
on
the
day
benefit
15,
of not doing a
we
large
hardly find
incision.
any scars
And
of
that's her colposcopy
4
after
boards.
3 months.
3 months later, when we do a colposcopy, we find a capacious neovagina, which is capable of easy vaginal dilatation or coitus with a very minimal amount of mucus.
They all continue to calibrate and
She, at this
dilate
point in time,
for the first 6
is
months.
a
Not
woman
that it's a
who
sigmoid
actually
segment
could
alone, but that's a wound which you have created
a
in
role
that part of
model
the
for
perineum.
all patients in future, a case who probably is feasibly taken forward and given a vaginal segment from the sigmoid. So a combined perineal and abdominal work.
So that's
has
how
brought
an
about
XI helps. I don't do
feasibly
this in
a
SI
satisfying
robot because it
post-operative
will not
outcome
help me.
to both the capacity and the
Do you
orientation of
fix that abdominal aspect of the new vagina?
Sacrocolpopexy, just suture it to the sacrum. No?
No, it's one side or both sides.
Just one side, no? Keep it in the center, make an axis, lengthen it up.
It don't be.
You have a vagina which is 15 centimeter long. You want it to be straight. Now when I do, I'll just show you the last video before we finish. So the last video is about that.
May I ask one question?
Quickly, I'll just finish the last
Yeah,
video. I'm running time.
It's very quick question. How you prevent infection in this type of patients? Because you are using colon for neovagina.
There's no infection. There will be some mucus discharge. It's very
Mucus
ghastly in the
and
beginning.
infection.
The patient never realized they will have a disaster of a mucus discharge because 15 centimeters of sigmoid will pour a lot. Not like ileum, but yes. But then we need to tailor that. It takes time. They keep dilating and bringing about a metaplasia on this for 6 months, 1 year. Gradually, the mucus discharge goes. There's no infection. Foul smelling thing can come because it's a ghost or a phantom vagina. Need to wash, douche at home. It becomes a part of your vaginal cleaning even at a very young age. You have a new organ given to you. I'm talking about the last kind of a short video. I've got that amount of time I promised to the secretary. I got a chance to speak at the TEDx talk on this subject, which we followed for the last 13 years in Mumbai. So this silent suffering, agony and anguish and discontent dilemma was what I wanted to talk to you. It was a request yesterday by somebody. I'll make the video very short. So this is probably my first recording of a gender reassignment male to female. But the workup on these cases have gone such that yesterday the government of India has passed the final guidelines. I was a part of it. And we will have this on the Ayushman Bharat scheme from next month onwards. And the secretary told me more and more doctors will do it, Dr. Pandey. So don't worry about it. I'm not sure how that will happen, but at the time when Rishi Guru was speaking on Ayushman Bharat, this was actually happening there parallel in Delhi. So need 2 psychiatric evaluations to prove that this is a gender dysphoria, not overnight dream.
Gender reassignment surgery.
And we go ahead with the surgery. I want to show you that original technique.
The incision is deepened to the level of the Colles fascia to expose the perineum in the place of future vagina. As we expose the Colles fascia and go to the scrotal part of the incision, the first ablative step is to complete the bilateral ocherectomy. Bilateral ocherectomy is completed with suture transfixation of the bilateral spermatic cord.
Out here the skin is
Penile
required
decloving
for
is
penile
started by a
inversion.
circumcoronal incision, and the circumcoronal incision allows a complete decloving of the penis down to the pubic symphysis. The degloved penis is then started for the penile disassembly.
So
The penile disassembly technique is a technique where we disassemble the component parts of the penis in a stepwise fashion. Urethra, which is catheterized, is then by a reason of sharp and blunt dissection dissected away from the corpora cavernosa. The neurovascular bundle, which is then dissected out from the corpora cavernosa, is started laterally, and the sharp dissection brings about the major part of the
I want to err on the side of corpora because corpora will come out. The neurovascular bundle has to stay.
This is an important aspect of preservation of the neurovascular bundles, which helps us in maintaining the blood supply and the sensitivity of the glans penis that happens to be the future clitoris. As we dissect out the corpora from the neurovascular bundle in its entire length of corpora, we reach the region of the pubic symphysis. The corpora is denuded of the entire neurovascular bundle very safely, taking into consideration the blood supply of the neurovascular bundle. The suspensory ligament of the penis and the blood supply in that area is then taken care of so as to bring about a corporal dissection and corporectomy bilateral. The penile disassembly technique brings about the entire penile disassembled into its various component parts. The corpora are then dissected away from the bones and excised. The excision of corpora and its transfixation brings about the completion of the ablative steps of the male to female single step gender reassignment surgery. The two testes and the corpora are then removed as a part of it. To bring about a complete disassembly, the glans is everted and dissected. The glans is then bisected in such a way that the dorsal half forms the clitoris and the ventral half would form the future neocervix. That is a complete dissection and division of the glans into two halves. The dorsal half would later on form the clitoris with the neurovascular bundles, and the ventral half with the urethra would later on be dissected to form the urethral inlay. The perineum is dissected and the central tendon is divided. A space is created between the prostate and the rectum, which allows
Dr.
the future
Kotwal does a
vagina
different technique altogether, and his is a
the penile skin tube is then lengthened by the way of dermal incision so as to increase the length of the vagina to a desired length. The urethra, which has been catheterized till now, is then decatheterized and planned for a dissection. The clitoris is created from the dorsal aspect of the glans penis with the neurovascular bundle kept intact. The penile skin tube on the dorsal aspect is then incised in the midline dorsally to bring about a partial thickness incision to maintain the vascularity of the penile skin tube in the entire length and to give a place for the urethral inlay to be brought about. The urethra is then incised dorsally to expose the mucosal aspect of the urethra, which should be utilized to increase the girth of the penile skin tube and would add on to the mucosal aspect of the vaginal tube. The mucosal aspect of the vaginal tube is brought about by suturing the divided urethra onto the inlay that has been created by the division of the skin on the dorsal aspect. Interrupted sutures bring about an increase in the girth of the penile skin tube on the inner aspect, which will also add to the mucosal aspect and would help in lubrication of the vagina. The neocervix is fashioned at the tip of the vagina with the ventral aspect of the glans as was described. The 6 inches vagina as created with the urethra inlay is then ready for positioning in the perineum. The dissected aspect of the perineum between the prostate and the bladder on the right side of the patient is ready for a sacrospinal fixation. The mold is then placed into the vagina to look at the regularity and the girth of this penile skin tube along with the tip, which happens to be the neocervix. The scrotal incision is then completed to bring about a perineal opening in its entirety. The Descamps needle is then used to fix the neovagina to the sacrospinous ligament of the right side, a way to fix the neovagina deep into the perineum by way of neocervix fixation by non-absorbent sutures.
And here we
The
fix
fixation
on both
is
sides.
placed
Sameer
into
Soin had asked about it.
the
Here we
perineum.
fix the vaginal vault on both sides compared to the sigmoid vagina.
Posterior fourchette is then created
goes and
from the
expands.
external aspect of the vaginal skin tube.
So skin tube has
The
to go and
suture
expand
fixation
out.
of that is brought about at the lowermost level of the perineal incision. The labia minora is created from the inner part of the scrotal tube, and thereafter we fashion the clitoris in a proper dorsal location, dorsal to the perineal urethrostomy or the neomatus. The neoclitoris is fixed in a position strategically to bring about the clitoris in this location happens to be strategic in terms of gratifying somebody because of its dorsal position to the urethra and the vagina. The anatomical positioning of the clitoris, the urethra and the vagina in that location. The central part of the incision is then closed to bring about mons pubis creation, and the bilateral labia majora are created.
So that should be the end of it. Thank you so much. I was trying to bring about an evolution. That technique has been changed by us. We don't do urethral inlay anymore. But it was all to look at an awareness which is a need today. Not that I'm a proponent of the subject, but got to do something on this subject and we went in to do it. The management is a dream teamwork because we got to get more and more of these patients come in. In India, transgender is equal to eunuch as well as gender dysphoria. The subject I was talking was gender dysphoria. The government of India has brought transgenders under the ambit of the Ayushman Bharat and wants all the eunuchs to be rehabilitated. And we'll end up doing a lot of vaginoplasty, sadly, for them. Now, eunuchs are a crime of our country. In India, Bangladesh, and Pakistan, we get a lot of eunuchs, and nowhere in the world you get these eunuchs anymore. So implementation is a challenge, and I'm sure more and more of colleagues will take up this subject because you will get redos. You will get these vaginas which are made of skin by your gynecologist or the peritoneal flaps, which only stand test of time in those few months. And you'll have more of MRKH and vaginal atrasias and more of these redos to come in around. Thank you so much, Mr. Secretary and the EZ-USICON Council for having invited me. In my end is a beginning. I've just finished in 1 hour and 5 minutes, and thank you so much. Thanks.
Thank you, sir, for your last slog over betting. And what would be the end apart from this session? It is just a slog over of the final 5 over or 10 over in a one-day international match. This was the last scientific program in our 3 days conference. Now I'd like to invite Dr. Ranjan De sir to and Dr. Arvind Agarwal sir and Dr. Sambhavu Prasad to kindly felicitate Dr. Sanjay Pandey sir. Dr. Pandey sir, kindly hold it. Sir, for the last session. A big round of applause for Dr. Sanjay Pandey. Dr. Agarwal sir, Dr. Agarwal, kindly stay here to felicitate the other chairpersons also. May I request Dr. Keshto Pradhan sir? And Dr. Savni sir? Oh, Dr. Sambhavu Prasad is already on the dais. Sir, come sir, please. And Dr. Sivaji Basu sir, say also. I'll also like to invite Dr. Samir Sain, the quiz master. Dr. Swain.
Wonderful. Sir.
Dr. Samir Swain, are you here?
Thank you. Thank you.
Now, for the valedictory function, I will request Dr. Ranjan De sir and Dr. Sam Babu Prasad to kindly be on the dais, and also Professor Animesh Das sir, Dr. Arvind Agarwal, President, East Zone Chapter of USI. I think Dr. Shambabu Prasad has all the results. Dr. Sam Babu, please come on the dais. You have all the results. Students are eagerly awaiting for the result. I will also like to invite Dr. Kollan Sarkar. Dr. Sam Babu. Yes. The students, are you here? You cannot make out much of you here. So Dr. Samir Sain has a flight, probably here. Probably he is backpacking or taking his lunch. Dr. Rangdeep Prasad Singh, sir, please, please come in the task.
Dr. Samir Sain, sir.
Samir Sain is outside for this please. শেষ হয়ে যাবে কল্যাণ সরকার হবে Oh, Samir. Dr. Samir Sain, please. Dr. Samir Sain, the quiz master. This is for excellent conduction of the quiz today morning. Thank you for the excellent Yes, sir. I'll also like to invite the chairpersons for the pediatric urology session, Dr. Harpreet Singh, Dr. Uday Chatterjee, and Dr. R.K. Gopal Krishnan to kindly come onto the dais and. Sir, Dr. Uday Shankar Chatterjee is here. Dr. Uday Chatterjee is here.
May we invite Dr. Uday Shankar Chatterjee, sir, to take the seat? Acha. স্টিকার আছে ঘোড়া ছবি আসছে হাইলাইটার I'll tell. Dr. Samish wants the result. With permission of Secretary Sir, Dr. Samish Shayan Sir wants to announce the result of the PDT quiz because he has to leave early. May I hand over the mic to Dr. Samish Shayan Sir?
Hello, it's a nice meeting for Vice June. So today I am announcing the result of Euro quiz in the morning. The winner is Dr. Wasim Molla from CNMC Kolkata. And second, that my runners up is Dr. Asutosh Kumar Tiwari, IPGMAR Kolkata. Give them a big hand, and they will be awarded with financial grant of 15,000 for the winner and 10,000 for the runners up. Thank you all.
So now Dr. Shambabu Prasad Sir is requested to announce the result of PDT papers as well as posters, video, papers and posters.
Sir, by the permission of President East Zone, I am going to announce the winners of the video, podium session, poster sessions, as well as essay. Now, the first position is obtained by Asutosh Kumar Tiwari in essay competition. Asutosh Kumar Tiwari, please. Asutosh Kumar Tiwari is from, I am saying, sir. Asutosh Kumar Tiwari is from 70. Asutosh Kumar Tiwari, please. Okay. Asutosh. Asutosh, which college? He is from IPGM, yes.
IPGMAR
SSKM, right. Thank you. He will get the check, sir. We'll give the check later on, sir. Okay. Now the podium session. Podium.
This is poster.
Podium session, parallel podium. Yeah, I have this one. The first prize goes to Jaid Ahmed Khan. Jaid Ahmed Khan. And second prize to the Sumintra Day. And along with the Soubhik Chandra, both have got the same marks. Sumantra Day and Soubhik Chandra for the podium. Over.
Poster. Now it
Now
comes to poster.
Now the poster. Poster session will go Subhajit Malakar. Subhajit Malakar. He has got the first prize and
Malakar from SSKM and IPGMER Hospital.
Wasim Malik. Wasim Mullah. He has got the one. Yes, he got the second prize. Now the video session. First prize goes to Dr. Prashant Nayak from AIIMS Bhubaneswar. Prashant Nayak, please. Yes. Second prize also to the Prashant Nayak.
This
Sir.
was presented by him.
Yes, sir. Yes, sir.
Yes.
Second prize.
Second prize.
Right. Third prize. Third prize is another one is Sir Piyush Kumar Patwari has got the third prize.
Thank you so much, Shambabu sir, for announcing the result. The certificates, medals will go in due time to your respective address.
And mic, please. And mic. And mic, please. Please stay there.
Thank you. It's my proud privilege to propose thanks to all the people who are involved in such a grand gesture. And first and foremost, I would like to thank Bengal Urology Society, Dr. Professor Ranjan Kumar De, who has been untiring, continuous, working for this proud moment that has come the day. We always thought we will never be able to make it. And in all those online meetings that we had several times, everybody was very skeptical whether we will be able to hold a physical conference at all. And there was COVIDs which were going up and down, and we thought it will be a completely online meeting. And then we thought probably 50 people will be able to attend. Then we came 6 months back. Then we thought probably ho sakta hai 75 people will come and stand somewhere, sit somewhere and do something. And till last month when the COVID started coming back again, there were around 500 patients coming in whole of West Bengal. So we were not very sure before the puja. With the puja, there is going to be escalation and it will jump, and then probably there will be no physical meeting at all. But Dr. Ranjan De had all the efforts going on, and with the support from Dr. Professor Animesh Das and the whole team of Bengal Urology Society, everybody came forward, right from Shivaji Da, Dr. Amit Ghosh, Dr. Anup Kundu, Dr. Dilip Karmakar, Dr. Pradhan, Dr. Kalyan Sarkar, everybody in, the whole of Bengal Urology Society came forward, and they all put together all their effort. And this is the effort that has brought this conference to a physical grand, and we will always remember the effort put in by the Bengal Urology Society in such an unprecedented time. We never thought we will be able to do it, but because of you, sir, we are here. We are very much thankful to you. Very much thank you. Thank you, sir. And I am very much thankful to our beloved secretary, Dr. Shambabu Prasad, who has been continuously in touch with the Bengal Urology Society, with Dr. Ranjan De, and has been able to make it to a present situation that we could hold the meeting. And I am very much thankful to the Urological Society of India, Dr. C. Mallikarjun, Dr. Keshav Murthy, Dr. Sabnis, who have come all the way from such far off places and have bestowed on us the whole guidance how to do things the right way. And I'm thankful to Dr. Lal Manani also, who has come and has been there with us. I'm thankful to all the members of the members who have come in such a large number. I came to know the numbers have crossed how many, Dr.
Of our members.
Total number?
Total number
300.
with spot registration has crossed 368.
368. I think this is the largest number they were ever collected at one place. Calcutta being the center, and Calcutta always was the center. And that is where anybody and everybody would like to come back because you do in a style which nobody else can match. Thank you very much, sir. I am very much thankful to the industry which has come forward. All the pharmaceutical industry, they have come forward, and Dr. Ranjan Dey is telling me it is because of them only that we are able to do what we are. Thank you very much. Thank you, sir.
May I invite Professor Dr. Kalyan Sarkar sir to say a few words as vote of thanks.
Good afternoon, everyone. It is my great pleasure to propose a vote of thanks. Now, this conference is a gathering of the national body of the Urological Society of India and its members, of the East Zone section of the Urological Society of India, and the Bengal Urological Society. It has been a great pleasure to have been a part of this conference. And this conference has been heavily supported by industry, which made it possible. At the outset, I would like to thank the chairman of the organizing committee, Professor Animesh Dash, and the indefatigable secretary, Dr. Ranjan Dey, without whose vision and efforts such a conference would never have been possible. Along with this was the enthusiasm of our president, Dr. Agarwal, and our secretary, Dr. Shyambabu Prasad, and the omnipresent Dr. Harpreet Singh, and also the various committee members of the organizing committee. They made this possible, and we were all guided by the past presidents of the various state societies. So truly, we never conceived that such a conference would at all be held. We were thinking of a very small, online and physical meeting. But all is well that ends well. We are delighted to hear these figures of participation. And I collectively thank all who have come in the audience till now, and I thank all of them who are there still at the end, at the terminal event of this meeting. From the national body, we have Dr. Sabnis, President-elect, and then we have Dr. Rajiv. I just saw he was there. And Dr. Pushkal Bagchi has been intimately associated with the financial aspects of the East Zone section of USI. I can see him. And of course, the senior members of the audience, Dr. Pradhan, Dr. Dilip Kormakar, Dr. Anjan Das, and Uday Chatterjee. And I think everyone has contributed in their own ways to making this a success. So the year comes to an end. I conclude my little talk by thanking the organizers, the various organizing bodies, and the participants, and above all, the millennial generation who is coming up
and who have taken such an active part in the deliberations in the conference. I think the future belongs to them. So, and finally, I conclude by thanking the industry and the trade and our secretarial staff, all of whom have worked their hearts out to make this a success in such a short period of time. Thank you.
The ceremonial function finishes. So after the presidential the lecture, the organizing secretary, honorary secretary, organizing chairman should say, and from the audience, we must get some speak from the state peoples. They should come and they should say, and lastly, the president-elect will say something, or the president-elect will take the charge. He will come, followed by the president-elect. This is the rule. Vote of thanks means you have finished the meeting.
Next, no. Thank you, Dilipda, for correcting us. I think
Dr. Arvind Agarwal, the outgoing president of the zone, the incoming president, Dr. Kalyan Sarkar, and the president-elect, Dr. Ranveer Prasad Singh, the secretary of the East Zone, Shyam Babu Prasad, and Dr. Ranjan De, the organizing secretary of this conference. Everyone in the dais, delegates from the East Zone as well as abroad, students, and the trade people and everyone involved in the conference. I think we had 3 days of absolute fresh air. When we were discussing about the holding of the conference, we all of us, I think, wanted a physical conference. And although there were lots of hurdles, lots of misgivings, I personally had full confidence in our two secretaries, the organizing secretary, as well as the secretary of the East Zone, as well as the presidents. And I also had a feeling that if we could hold this conference, there will be an enormous attendance. Because I thought I had the pulse of the people, of the doctors, of our friends and everyone. Anyway, we had 3 days of wonderful entertainment, academic entertainment in the form of excellent papers, presentations, and I think 3 evenings of full-fledged entertainment where people mixed with each other, met each other, and shed off all their inhibitions and gave vent to their feelings and emotions. I hope you have enjoyed, all of you, these 3 days of your stay over here. And nothing will be more rewarding for the organizing committee than if you have loved and enjoyed this conference. I would ask your forgiveness for any hitches and glitches that may have occurred. And finally, I thank the organizing president, the organizing secretary of the East Zone, Dr. Ranjan De, at the helm again, as I said, with his team, our BUS council, and all the delegates, especially the senior ones from abroad. It was great encouragement in their presence over here. The trade people and all supporting staff who enabled us to make this conference a real success. Thank you.
Thank you, Professor Animesh Das sir. Now I'd like to invite Honorary Secretary East Zone, Dr. Shambhavu Prasad, to have some word.
Most honorable and respectable dignitaries on the dais and off the dais, our respected President, Dr. Arvind Agrawal sir, President-elect Dr. Kalyan Sarkar sir, and President-elect Dr. Ranveer Prasad Singh sir, our organizing secretary, our beloved Dr. Ranjan Kumar De sir, Chairman Organizing Committee, Dr. Animesh Das sir, dignitaries present in the hall, our national faculties, our zonal faculties, students, people of the industries and pharma company. We have worked 3 days without taking rest, and finally we completed this conference. That was the problem, that we are thinking that it will get happen or will not get happen. Last 1.5 months, the work we have done, especially the organizing committee under the leadership of Dr. Animesh Das and Dr. Ranjan Kumar De, have worked day and night, and that is the result. That's why we have done this conference physically. Initially, 1.5 months back, there was uncertainty that we can hold this conference physically or not. There was some sort of thinking that the web meeting will happen, hybrid meeting will happen, but we decided that this conference will go physically, because last year we announced the 0 year, and we don't want to repeat the same type of things this year also. And we took the feedback from the national bodies and all the other bodies, and they asked that they also have planning for the physical conferences and moving towards the physical world, because everyone wants to get together and meet each to others and greet our beloved friends. We, as a secretary, East Zone chapters of Urology Society of India, we faced, I learned and I worked under the 3 presidents, our important presidents. First under Dilip Kumar Pal, second under the Arvind Agrawal, and third Dr. Kalyan Sarkar. Under 3, I have worked and got the exposure of how we worked in the society and how we work, how anyone can work in the East Zone or USI as a secretary. And I have the opportunity to learn many things from these illuminaries and dignitaries of our zone. I am fortunate and I have privilege to learn many things, how to work, how to meet and convey the messages to each and every members and interact each and every members of the society. And I feel that the further secretary who is going to take over will continue the same tradition, because I am very much happy that our successor who is going to take over the office is very much efficient to do and deliver the work properly. So our president, Dr. Kalyan Sarkar, is also the vision to improve our zones academically as well as in different aspects and different ways. And similarly, our dynamic secretary is also taking over. I also thanks to each and everyone who has helped me in organizing this conference, as well as helping me the 3 years as an honorary secretary. If from my part anything has got wrong, I want the personal apology, and especially from the seniors peoples who are watching us and working, and we are assessing everyone to what they are doing, either honestly or dishonestly. So if anything has gone mistake from my side, I want the personal apology. I thanks by saying these words. Thank you, everyone.
Thank you, Dr. Shambhavu Prasad. Now I will request Dr. Ranjan Desai, Organizing Secretary.
Good afternoon, everybody. This is the validatory session is going on. Validatory session means the ending of this conference, but I don't know whether it is ending for my work, because I am finishing this session as organizing secretary, and with your grace and love, I am taking over the charge of the secretary from the next day. This is a great transit from organizing secretary to the secretary. All it is possible because you people have supported me so much over this year. In a very short span of period, we have organized this conference. There may be some loophole in constitutional rules. There may be some loopholes in arranging the program. I apologize in the same tone that please pardon me if I make any mistake in this state. But for organizing this this conference, I must say the support I have got from my council and my seniors. I don't want to take name individually. Everybody knows how much they have supported me. My younger brothers and my elder brothers, all of them has supported me very much. And today it is possible that 368 delegates were participated in this conference, because one reason may be the COVID rebound phenomenon, that for the last 2 years, they could not attend any physical conference. Number two, the city of joy. And number three, may be our good luck. But all this good luck has been created by the trade. From the beginning, I told my trade friends, you are not no more the provider for this conference, you are also the delegate for this conference. So with these very small words, I also want to extend my extreme gratitude to my event manager, Mr. Abhishek and Mr. Sunil, for organizing this program flawless. I think they deserve a very big clap for their excellent support, and also the JW Marriott Hotel for giving this opportunity. I don't want to extend my words any further. I just want to say thank you very much again. Thank you.
Big round of applause for our organizing secretary, Dr. Ranjan Desai. Now it's time to also giving thank to our trade people. I will request due to time constraint, three of you from Sun, Alchem and IPCA to if you can come to the dais and say a few words in short.
Good afternoon, sirs. This has been a wonderful conference from the day it was planned, I believe. And we honestly thank the organizing committee for giving us the opportunity to be a major player in this 30th East Zone USI conference. And we wish we move together to the next year with a much more enthusiasm and working as a unit and unitedly. We wish we could come to your requirements, being the #1 company in India and 4th largest company in the world. Sun Pharma has been a major player with USI, the zonal chapters of your committee and the state chapters. And we are confident and we assure you that Sun Pharma will keep on being the major player going forward. And I thank personally Dey sir for giving us this opportunity along with the help of all of you sitting over here. Thanks from Sun Pharma and my colleagues. We both work together and giving us the opportunity. Thank you very much, sir. Thank you very much.
Good afternoon, everyone. First of all, I thank Dr. Ranjan Dey sir for giving us this wonderful opportunity. We as a IPCA Neurosciences, as a team, everyone has stood forward to make this as a grand success. And finally, I congratulate the wonderful 3 days E-Zone fees, academic fees. No doubt, everything has been covered up right from yoga session to the PG quiz. And last but not least, we would continue from IPCA Neurosciences such academic support to the USI body. Thank you very much.
Good afternoon to all my seniors, and I thank Dr. Dey to give us this opportunity to come to this dais and express my gratitude and thanks to all of you for making this conference a grand success. And definitely all my colleagues have previously shared the things. I want to share one thing that we in Bengal, we in Calcutta always support our culture, our heritage. And that is quite rightly expressed by our organizing secretary today by his apt dress. So I once again thank all of you, all the delegates who have come from outside and all the delegates who have come here, that we represent the city of joy, we represent culture and heritage. And from Alchem Eurocare, I once again thank all of you. Thank you, sir.
Thank you, sir, for giving this opportunity. It's now my pleasure to invite some of the esteemed members of our society and our national body to say your few words regarding how there was a conference, your experience regarding this 3-day conference. I will request Dr. Sabni sir to say few words regarding this conference.
I must congratulate my Well, the conference has come to the end, and I must congratulate for organizing a fantastic conference. Well, I have seen so many conferences in past so many years, and attended the various zonal, national, international conferences. But this is the one conference post-COVID, almost after 2 years, organized in a perfectly flawless manner. And I must congratulate specifically to the whole organizing team, Dr. Animesh Das, Dr. Ranjan Dey, the whole team and the Bengal Urology Society to have put so much of efforts. Well, 368 members for the East Zone USICON is a really record-breaking number. Even we had a West Zone conference, which we were also a little bit dicey whether it will happen or not. It happened in a very nice way. About 250 people came, but it was half hybrid. I mean, hybrid and the thing almost mixed. This was more of a physical conference, and probably this is the conference which has set the ball rolling, that over here the COVID fear is over, and now we are entering into the old normal. All the time we were talking about the new normal, now we are entering into the old normal, which we are all used to for so many years. 360 people coming is not a joke. I don't think they have come just because the Kolkata is well connected. They have not come just because it is easy to travel. They have not just come because the COVID is on the decline. They had the faith in the organizing team. They had a faith in you. And probably that's the reason why they came in such a big number in such a short time. Because once you organize this conference, once your name is there, when the whole Bengal Urology Society with full dedication, they are there. They knew that result is going to be excellent. And that, I think, tempted them to come in such a big number. So that is the whole success of this conference. All 3 days I have been watching. In fact, East Zone USICON, I must have attended all consecutive East Zone USICONs for so many years now. Year by year, the conference standard is being elevated. In fact, you are breaking your own standard all the time in the years to come. And I'm sure this conference has elevated the standard so much that in a successive year, it's going to be difficult for people to maintain such standard wherever they are organizing the conference. So I must say this dedication, this enthusiasm is of a great relevance. And all of you have taken real personal care of every delegate. I was talking to you yesterday that you were personally inquiring each and every delegate, each and every trade people, which I think is very important. Everybody you treated as if they're your personal guest, and that makes an impact and that makes a difference. And success of this conference actually is because of this. So I congratulate the whole team for organizing such a fantastic conference and giving us the opportunity to be the part of this conference. Thank you very much.
Thank you, sir. I'll like to request Professor Dr. Dilip Kamakar sir to say a few words.
Good afternoon, and thank you to all the delegates. And that's why I'm saying that the whole team, Ranjan, Kullan, Animesh, Sham Babu, and Amit Agarwal, they did a hard work. We can't think that we could be organized these types of conference. Even at any point, Ranjan asked every senior peoples, intermittently, in the monthly intermittently, we did a meeting. And actually, our conference, these scientific sessions, I'm in this society, we are doing this conference since 1991. I can say you, the standard is now at par with national level. And henceforth, we don't need to call people from outside. Our boys are so much academicians, they can continue it very well. And lastly, I could say that Ranjan is allowed by his family to organize this conference, because without the family support, nobody can organize these types of works. So if Ranjan's wife is here, I will invite him. Yes. Oh, so we must give a clap to her. Thank you to all members.
Now it's my pleasure to invite Dr. Ranbir Prasad Singh, of President-elect East Zone, to.
Sir has to take a flight. So we are allowing, sir is senior. Sir has to catch up flight.
Thank you, organizing committee. Good afternoon to everybody. I am really thankful to all the members of East Zone, the council, for giving me the opportunity to serve you as a president 22-23. This is not any political post. Our job is to look to do our duty and the responsibility, especially in academic field and the training field. This organization is for the welfare of our members, mainly the postgraduates who are the budding urologists, future urologists. So this should be, and every step this should be kept in mind. Other fun and joy is all right. It is one of the part of this, but duty and responsibility our is to keep the academic forum alive. Thank you again, everybody, to make this conference, mainly the organizing team and the whole Bengal Urological Society, for this wonderful, wonderful, wonderful congregation and thank you so much.
So from audience, may I request Dr. Harpreet Singh sir to come on the dais and say a few words.
Good afternoon, everybody. I'll not take long, but this is important. Arvind Agrawal sir, President, Honorary Secretary Shyam Babu, President-elect Kalyan Sarkar sir, Animesh Das sir, my friend Shyam Babu and Ranjan De sir, and all our past presidents of EZ-USICON and the senior member and Dr. Savnis. Very good afternoon. I think all good things come to an end. And see, last year we were one step behind and 2 steps forward. Last year we were the only zone who had taken a step backward, and we ourselves feeling very bad. But but this year we have taken 2 steps forward, so we are not lagging, and we have proved ourselves. I thank East Zone Council as well as Ranjan Dey and his full team, organizing secretary and his full team, who have done a wonderful job, along with the Bengali Urological Society. And I must say that choosing the venue, deciding हम लोग कभी हाँ कभी ना, हमारा तो यही लव अफेयर चल रहा था, करें कि नहीं करें, हाइब्रिड करें कि ये करें. But taking the things and in between, as Karmaka sir mentioned, Madam got sick, so Ranjan sir was pulled along on many sides. But at the end, his hard work, his warmth, and prevailed over everything, and you can all see the conference, and we had an all-time high registrations. I want to thank the support team. I not remember many names, but at least you can see Samanjit, Barun Shaha, Nirmalya, Abhishek. There are all people who have been there. Many are just missing the name, but they have worked very hard behind this. And our Rajesh, who is doing the registration. And I thank you, everybody, and thank Ranjan sir. Congratulations, you have done a wonderful job. And I'm sure Shyam Babu will not rest. He will. He has a hard task next year. So best wishes to all of them. Thank you very much.
Now, may I request sir to sir इधर आ जाइए, podium में आ जाइए, please.
I am Dr. Lal Malani, and the only thing I want to tell Shyam Babu and Ranjan here, माफी वाफी नहीं, हम लोग को बहुत मजा आया. आपका प्यार मोहब्बत इतना ज्यादा है, इतना खुशी हुआ हमको कि 2-3 दिन आपने इनवाइट किया और हम लोग आए. और आई एम श्योर जितने भी आउट ऑफ कोलकाता, आउट ऑफ ईजोन आए, सब लोग बहुत खुश है. एंड योर लव एंड योर रिगार्ड्स विल ऑलवेज मेक अस कम टू यू अगेन एंड अगेन. थैंक यू.
Dr. Bhatyal from Delhi. I've been greeting to you from North Zone. I think I'm the sole representative now. It was a fantastic conference, and the hospitality was unparalleled. And academic bonanza cannot be compared. as Dr. Sabnis very rightly said, that it has gone to a very, very high level and the other zones would follow suit. Thank you very much and heartiest congratulations.
Dr. Lalit Shah, sir, please.
Thank you very much for a very, very grand conference and invitation and everything. But I have a very big complaint against Dr. Ranjan Dey. He has not left any place for complaining, and that is not good. Thank you very much.
Now, may I request Dr. Sanjay Pandey, sir, to say a few words of thanks? Please come on the podium, sir.
কেন আমি একটু বাংলা বলতে পারি সবাইকে নমস্কার জানাচ্ছি রঞ্জন দা থ্যাংক ইউ সো মাচ এন্ড দ্য এন্টায়ার ডেলিগেটস আউট হিয়ার ମୁଁ ଟିକେ ଟିକେ ଓଡ଼ିଆ କହିପାରେ because I was born in Orissa and therefore it feels good to come back to the zone একটু ভোজপুরি বলে আমলা তো Harpreet and Prem are always very good friends so I think it looks good to me to come back here again and again I feel a part of this in Santi Niketan it's wonderful thank you so much thank you all
Dr. Krishna sir
Dr. Krishna Pradhan sir is one of the senior most faculty of our state and zone. It's our real pleasure to invite sir in the dais.
I thank the organizing committee to arrange this conference, a grand success. Since 1984, I'm attending all the national and zonal conferences. Hardly I missed any of them. And from those days, if I look back, there is only few members who used to attend. But now you see from our east zone, now it is more than 350 because we are in the process of phasing out. I am very much pleased that young generation is coming up who will take over the charge to serve urological service to our part of this country. I thanks everybody and this society should come forward and more this young generation, they will be motivated to do urological practice and give service to the India. Thank you very much.
Now, may I request Dr. Shivaji Basu, sir, please come, sir. It is our honor, it is my personal and organizing committee honor to invite you on the dais. A big round of applause for sir.
Actually, I missed the bus. I was stuck in this disturbed hilly areas, just arrived now. But I was keeping a watch online on the sphere programs, not to speak about the yesterday night's dances. But as soon as I entered, what struck me was the trade people were so happy. That is the index, as Sabnis was saying, that's the index of a successful conference, and not to speak about the 360 happy delegates. And at one time, we were very depressed that we are all going down, the new generations are not taking charge, what will happen to the urology? That picture is changed totally. And as I always believed, like other few friends, that there are so many capable young boys, they can take the charge of the urology, the zone, and obviously on the national level as well. I'm so pleased, and under the leadership of Ranjan and the other friends, everybody, Shambabu and Amit Agarwal and Ranjan's whole team. I mean, you cannot name them. And I feel so sorry for the first time, and I missed the conference, and what a conference it was. Thanks to everybody.
Now, may I request Dr. Rajiv TP, sir, if sir is present in the auditorium, to please come on the dais.
Probably sir is in outside lunch section. I will, sir, like to invite some from audio visual team. Abhishek, will you like to say someone? Before that, I will request Dr. Ranjan Das sir to please share a few words. Please, sir.
Please, sir, pardon us, sir. Give us a few words of blessing and suggestion.
I just want to say thank you to all the invitees and all the people, delegates who has come from other states. Thank you.
Now, may I request our new Bengal Urology Society Secretary, ever dynamic, ever energetic, Dr. R.K. Gopal Krishnan, sir, to say a few words of blessings and suggestions.
Well, Dr. Ranjan Dey said that he was helped by the members of his BUS council in this work. We were only trying to shadow him, but this man by his work has become so huge that the shadows were very small. I think he has done the entire job on his own, although he gives us the credit. That is the magnanimity of this gentleman.
Dr. Pushkal Bakshi, please.
Thank you. So this conference is really memorable one. Actually, we were having council meetings many times before this conference, whether we will be able to hold this conference or not. Initially last council meeting, we decided to hold a hybrid, but seeing the participants here, forget about all hybrid and everything. Now, really, the time has come that we can do something after COVID. So thankful to everyone, and thanks to Professor Ranjan Dey and his entire team. And one thing I want to say that I am the treasurer of this organization for last 3 years, and I have extended to another 2 years now. So I want to say working with Dr. Shambabu was very different. He is a very simple person, and he is a very positive-minded person, and he was what I should say about him, that enter this conference, he time to time he used to ring us and used to take the feedback of everything from us, from our department, as well as from me also, what to do next and what not, and everything went so smooth. And regarding Professor Ranjan Dey and his Animesh Das sir, my special thanks to everybody of Bengal Urological Society. Thank you very much.
Thank you, sir. I'll also like to invite, if there is some representative on behalf of JW Marriott Hotel, to say a few words regarding your experience. Oh, okay. Now it's time to our official handover of charge. Before that, if anyone from you or the audience like to share a few more words, if that is done,
anyone sitting in the hall wants to say something, please come on the dais, sir. Okay.
Now, Dr. Arvind Agarwal is going to change his baton to Dr. Kalyan Sarkar. Dr. Kalyan Sarkar.
Invite Professor Kalyan Sarkar, sir.
Sir.
Yes, welcome to this.
I am overwhelmed that the governing body of this society has chosen it fit to elect me president for the next coming year. I take over from a very good friend and associate, Dr. Arvind Agarwal. And I hope that I will be able to fulfill the expectations of the society. The world has just woken up from a COVID slumber. Now, everyone is in a hyperactive state of mind, and we want to catch up with what has not been done in the last 2 years. And the first and the most important thing that I want to tell you about my vision for the coming year is that I'm sure that that the outgoing governing council had a lot of unfinished dreams, and I would very much like to work with them together along with our new secretary, so that we can give a mix of true academic activity foremost, along with extremely good fellowship. And I hope that the members of the trade will support us in our future endeavors. And last but not least, I would want the new generation of doctors referred to by all our previous speakers, people who are urologists who are now coming into the prime of their profession, and neurologists who are entering the profession. These are the two segments of urologists I would like to involve actively in all future endeavors. Thank you very much indeed for giving me this opportunity.
Thank you, sir. Sir, I now like to invite Dr. Shambhavu Prasad and Dr. Ranjan De to officially shake their hands.
Change of secretary. Okay. Sir, I am very happy to inform you, all the delegates sitting in the hall, that I am giving the charge to the most able person of our zone, that is Dr. Ranjan Kumar De. Please, Dr. Ranjan.
Professor Dr. Ranjan Kumar De, sir.
Now, vote of thanks from Dr. Ranjan Kumar De.
I have already spoken my gratitude to all of you, and I am a little scared right at this moment, because the rules and regulations and the formalities of running a association properly, along with its academic activity and also social function and friendship fellowship, all these things requires a lot of effort. I hope I will get the courage and the help from everybody, so that in the next 2 years, with the help of our two next president with whom I will have to work in the next 2 years, Dr. Kalyan Kumar Sarkar and Dr. Ranbir Prasad Singh, I will be able to deliver. But at this moment, it is my duty to name few of my junior brothers, those who have really helped me in organizing this committee. I have already expressed my gratitude to the trades and their kind help they have made to make this conference. I have to name Sharanjit Chatterjee, I will have to name Dr. Bodun Shaha, I will have to name Dr. Nilanjan Mitro, I have to name Dr. Tarun Jindal, I have to name Dr. Devmallo Gangobadhyay, I have to name Dr. Joy Sen Sharma. Where is Joy? Joy is eating. Dr. Joy Sen Sharma, Dr. Saptarshi, everyone whom not, everybody, Dr. Amit Ghosh, Dr. Kalyan Sarkar, and my senior brothers like Dr. Dilip Kormukar, Dr. Anup Kundu, Professor Ranjit Das, everyone helped me to organize this conference. And I am also grateful to Dr. Shambhavu, who is a very simple person. He may not follow all the rules, but heart is so pure, no stain can be put on his effort. Thank you very much, Shambhavu. And at the end, I thank হ্যাঁ, ন্যাশনাল অ্যান্থেমটা কে করবে? তোমরা করবে, বাজানো হবে। Okay, and thank all the delegates for your excellent participation and making this conference successful. Thank you. এবার আমাদের জাতীয় সঙ্গীত হবে, সবাই একটু উঠে দাঁড়ান। হ্যাঁ, না, followed by lunch. First the national anthem, উঠে দাঁড়ান। ছবি তুলে নাও। ন্যাশনাল অ্যান্থেম শুরু করো, শুরু করো। অনয়দিনায়ক জয় হে ভারত ভাগ্য বিধাতা, পঞ্জাব সিন্ধু গুজরাট মারাঠা দ্রাবিড় উৎকল বঙ্গ, বিন্ধ্য হিমাচল যমুনা গঙ্গা উচ্ছল জলধি তরঙ্গ, তব শুভ নামে জাগে তব শুভ আশিস মাগে, গাহে তব জয় গাথা, জনগণ মনোবল জায়ক জয় হে ভারত ভাগ্য বিধাতা, জয় হে জয় হে জয় হে জয় 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 হে। Long live Bengal Urological Society and East Zone chapter on Urological Society of India, which is part of the father organ or mother organ Urological Society of India. Thank you very much. And the lunch is open. We can join our lunch just now. The farewell lunch.